So here, musculoskeletal system, few questions you have solved in the last class. First question, open reduction of ulnar shaft fracture you have to code for. So what happened to your patient? Fracture. Which part of the body or which bone is fractured? Ulna. So where is ulna located? You have to find out that. Ulna is a bone of your forearm. Okay, so you will go to the section forearm. Into forearm, you are going to go to fractures and dislocation because the doctor is treating a fracture. So you'll go to fractures and dislocation. Then into fractures and dislocation, you'll search for the bone ulna. And for ulna, there will be three codes, like for the proximal end of ulna, then a shaft of ulna, the lower end of the ulna, distal end. For every part of the ulna, there will be different codes for the treatment. So of that, which part of the bone is fractured? Shaft is fractured. So check for the open treatment for ulnar fracture. So open reduction, that is what is you have to match, and the part of the bone that is fractured is shaft. So if you match, you will get the code 25545 will be your correct code. Coming to second question. Question number 2 is for orthopedic surgeon reduces a fracture of right proximal tibia. After close treatment and skeletal traction, the physician applies a short leg cast. So that is what is you have to code for. Now here, again, you have to check which bone is fractured. Tibia. Tibia is your shin bone. So you have to go to your lower extremity, lower leg, you will go to. And then which part of the bone is fractured? Tibia. Okay, so tibia and that too proximal end of tibia is fractured. And I told you whenever you're coding for long bones, if you're coding for the proximal end of any long bone, then you have to check it into the respective joint. So you have to go to knee joint here. In the section knee joint, you will find the codes for how the doctor is treating this fracture. Here it is a closed reduction that is done. Okay, doctor is reducing the bone, means he is by using his manual forces, he is bringing the pieces of bone back together. That's a closed treatment he's performing. So closed reduction for proximal tibia is done, and that is what is your code for. And the correct code is 27532. RT is the modifier for right side because they are treating the right knee joint. So that is why you will use modifier RT. Coming to third question. The patient is diagnosed with closed right humeral shaft fracture. The orthopedic surgeon performs open treatment for the fracture using an intramedullary implant and locking screws. So here again, which bone is fractured? Now it's shaft. So you can go to that humerus is the upper arm bone. So you'll go to upper arm. Under upper arm, again, you'll go to fractures and dislocations, and then you're going to code for what so the type of fracture is closed fracture, but the type of treatment performed is open treatment. So search for open treatment for humeral shaft fracture by using this screws and implants. So when you match that description, you'll get the code 24516. Again, RT is the modifier for right side because they are treating the right humerus. Coming to fourth question. It's for arthroscopic synovectomy of the left knee. So the procedure is performed on knee joint, but I'm not going to go to knee joint. Why? Because they are treating it arthroscopically. I told you there is a last section into your chapter, arthroscopy and endoscopy. So whatever part of the body they are going to treat, all your procedures which are performed endoscopically or arthroscopically, you will find the codes in the end of the chapter in that section. So here you will go to that last part of the chapter where arthroscopy and endoscopy is listed. And there you will start searching for this description. You will get your code 29875. That is the correct code for synovectomy of the left knee joint. And this is LT is the again modifier for left side because they are treating the left knee joint. Question number 5, surgical exploration of the stab wound of chest with included coagulation of blood vessels and enlargement of the wound. So here, what the doctor is doing, he's treating a stab wound. Doctor is going to explore the wound, is going to coagulate the blood vessels, and he's going to enlarge the wound for exploration. So whenever it's an exploration of any penetrating injury, like gunshot or stab injuries, we saw there are codes listed under the general category. The very first part of the chapter, general category, there you will find the codes for penetrating injuries. So there you will find this code. The codes you just have to choose based on the location. Where the wound is located on the chest, so match the location, you can choose your code. Everything else is included in the same code. That coagulation of the blood vessels, enlargement of the wound, everything is included in that. You don't have to code for these things separately. So correct code is 20101. Next, question number 6. It is for 4 trigger point injections of 3 muscles. How many muscles the doctor is going to treat? 3 muscles. And he is performing this trigger point injection. So for the trigger point injection, again, this codes, they have not mentioned which muscle they are just going to inject into. So I don't know which muscle is being treated. I cannot go to the specific body part. So I just am going to go into the part general category. And under general category, introduction codes, because the doctor is injecting, a needle is being inserted into the patient's body. So under introduction, general category, introduction codes, you'll find this code for trigger point injection. And whenever you choose the number of muscles being treated with the code description, and you'll get your code. So for 3 muscles, the correct code is 20553. Okay. So that is how all these questions. That's different with 20561, the trigger point injection. 20561. Yeah, 20561. Also, one. But is it a trigger point injection? Yes. Okay. 20561, right? Above. With that. Okay. What is it? Needle insertion without injection. So in the pillow. Yeah. It is injection, single or multiple trigger point. Okay. Yeah. Download the 20561 the hashtag. Yeah, this is for 3 or more muscles. But what is this code for? It is for needle insertion without injection, 3 or more muscles. So when you read your code, you have to start reading whatever part of the code up to the semicolon that will remain constant for the next code, because this code is slightly, the description is indented to left and it starts with a small alphabet. So when I'm reading the codes, I have to read it needle insertion without injection, 3 or more muscles. So it is, you just are inserting a needle, but you're not injecting anything. In your patient, they have injected. A trigger point injection is performed. So when it's an injection, single or multiple trigger points, then you have this code 20553. Okay. So that whatever you were saying, it was without injection, only insert a needle. That's it. Any doubts for anyone in any of these questions? No?
No, ma'am.
None.
Okay, fine. So we are going to start with a chapter that is nervous system now. Okay. So for nervous system, what I'll do is I'll just play a short video to make you understand the normal anatomy and physiology of the nervous system, because those who are not from medical background, for them it is important to know all the different parts of the brain, which part of the brain has got which function. So for every part, there will be a specified function. You have to know, like a vision is taken care by which part of the brain, which lobe, like cerebellum, or like midbrain, which part of the brain takes care of vision, which part of the brain takes care of your like motor senses or sensory information and so on. So all that will be played into the video. Apart from that, they will explain about the spinal cord and then different types of nerves. So all your nerves are scattered everywhere into the body. They form your peripheral nervous system. And these nerves, few of the nerves carry signals from different body parts back to your brain, and few of the nerves will carry the signal from the brain back to the different body parts. So Well, depending on the function of every nerve, the nerves are classified into different types. So I have not explained this during your anatomy physiology class because I said we will go into the details when we will just go to the nervous system into CPT. So here in the video, everything is explained into detail. Pay attention to all different types of nerve, different parts of your brain, what are the functions of different parts of brain, and what is the function of spinal cord and different parts of spinal cord. Okay. So just go through it and then we will check the codes.
You've never seen before.
The great and mighty nervous system, or the brain as most of us call it. What makes this organ unique is that within it lies the ability for humans to know oneself. This feature distinguishes and sets the human species apart from the rest of creation. This ability is known as consciousness or intelligence. To begin, let's look at the primary function of the nervous system. The basic purpose is to coordinate all of the activities of the body. It enables the body to respond and adapt to changes that occur both inside and outside the body. Now, the nervous system is actually split into two parts: the central nervous system and the peripheral nervous system. We'll explore the peripheral later, but first, let's look at the central nervous system. The central nervous system is made up of two major structures: the brain and the spinal cord. As most people know, the brain is found within the cranium or skull, and there are 6 main sections among other structures within it. These 6 sections are the cerebrum, cerebellum, diencephalon, the midbrain, pons, and the medulla oblongata. The first section is the cerebrum. This is the largest section. It's divided into 2 major hemispheres, which are the right and left hemisphere. And the cerebrum is further divided into 4 lobes. These 4 lobes are the frontal, the parietal, the temporal, and the occipital. The frontal lobe is primarily responsible for reasoning and thought. The parietal is primarily responsible for integrating sensory information. The temporal is primarily responsible for processing auditory information from the ears. And the occipital is primarily responsible for processing visual information from the eyes. The second section of the brain is the cerebellum. This is the section located in the back of the head, below the cerebrum, and above the first cervical of the neck. It is responsible for muscle coordination, balance, posture, and muscle tone. The diencephalon section is found between the cerebrum and the midbrain. It contains 2 structures: the thalamus and the hypothalamus. The thalamus behaves much like a relay station and directs sensory impulses to the cerebrum. And the hypothalamus controls and regulates autonomic nervous system functions such as temperature, appetite, water balance, sleep, and blood vessel constriction and dilation. The hypothalamus also plays a role in the emotions such as anger, fear, pleasure, pain, and affection. The midbrain section is located below the cerebrum at the top of the brainstem. It is responsible for certain eye and auditory reflexes. The pons is located below the midbrain and in the brainstem. It is responsible for certain reflex actions such as chewing, tasting, and saliva production. And the last section is the medulla oblongata. It's the lowest part of the brainstem, and it connects with the spinal cord and is responsible for regulating heart and blood vessel function, digestion, respiration, swallowing, coughing, sneezing, and blood pressure. It's also known as the center for respiration. Now that we've covered the brain, let's take a look at the other half of the central nervous system, The spinal cord. The spinal cord is the link between the brain and the nerves and the rest of the body. The spinal cord is divided into 4 different regions: the cervical, thoracic, lumbar, and the afferent and efferent spinal nerves, which merge to form the peripheral nerves. The afferent spinal nerves are responsible for carrying information from the body to the brain. And the efferent spinal nerves are responsible for carrying information from the brain to the body. Now, within this elaborate system of nerves, neurons, and dendrites, there is a system that regulates the functions of the central nervous system, which lie outside its major components, such as the brain and the spinal cord. This system is known as the peripheral nervous system and is subdivided into 2 smaller systems: the somatic system and the autonomic nervous system. The somatic nervous system is responsible for carrying motor and sensory information both to and from the central nervous system. This system is made up of nerves that connect to the skin, sensory organs, and all skeletal muscles. The somatic system is also responsible for nearly all voluntary muscle movements, as well as for processing sensory information that arrives via external stimuli, including hearing, touch, and sight. The structures that allow this communication to happen between the nerves throughout the body and the central nervous system are known as the afferent sensory neurons and the efferent motor neurons. Now, afferent simply means conducting inward, and efferent means conducting outward. So just like in the spinal nerves, the afferent neurons take information from the nerves to the central nervous system, and the efferent neurons take information from the central nervous system to the muscle fibers throughout the body. The autonomic nervous system is further divided into the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is vital to our survival. Have you ever heard of the fight or flight response to danger? The sympathetic nervous system revs up the body when confronted with imminent danger to either defend yourself or to escape the threat. The parasympathetic nervous system is the counterbalance to the sympathetic response to danger, whether real or imagined. Once the threat is gone, the parasympathetic brings all the systems of the body back to normal. Now, at this point, you should have a basic understanding of the nervous system, but let's do a quick recap. The basic purpose of the nervous system is to coordinate all the activities of the body. It enables the body to respond and adapt to changes that occur both inside and outside the body. The 2 major parts to the nervous system are the central nervous system and the peripheral nervous system. The central nervous system is also divided into 2 major structures: the brain and the spinal cord. The brain is found within the skull or cranium, and it is made up of 6 main sections. These 6 sections are the cerebrum, cerebellum, diencephalon, the midbrain, pons, and the medulla oblongata. The other half of the central nervous system is the spinal cord, and the spinal cord is the link between the brain and the nerves and the rest of your body. The spinal cord is divided into 4 different regions: the cervical, thoracic, lumbar, and afferent and efferent spinal nerves, which merge to form the peripheral nerves. Now that we know the brain and spinal cord primarily make up the central nervous system, let's look at the peripheral nervous system. The peripheral nervous system is essentially the nervous system outside of the brain and spinal cord. The peripheral nervous system is then subdivided into 2 smaller systems called the somatic nervous system and the autonomic nervous system. So, as you can see, the nervous system is quite complex, and this is just the tip of the iceberg.
Okay, that was all about the nervous system. Now we will check the codes into nervous system. Here it starts on page number 456. If you open page number 456, there is a diagram for the nervous system. So all the important parts of the nervous system, they have listed into this diagram, and the important nerves also are named into this diagram. So the names of the nerves, it is quite difficult to just memorize all the names of the nerves. So leave that part. But the parts of the brain and the parts of the spinal cord, at least you should know and you should remember which all parts are there, what are the functions of every part, because under the anatomy physiology section, you will have questions related to this. Here, this is the diagram. And then the next page also, there is a diagram for all different parts of the brain. They have listed into this particular diagram. And on the next page, you will have codes starting for nervous system. When it comes down to coding into nervous system, your codes are divided into three major sections. The first section under nervous system is all related to procedures performed on brain, skull bones, and the nerves, which or maybe your protective membranes of the brain. So, protective membranes of the brain are called as meninges. So, there are three protective membranes for your brain and spinal cord. That is pia mater, arachnoid matter, and dura mater. That we have already discussed, and in the like I'll play another video so to make you understand, because where you are going to perform the procedure below, like the outermost membrane of the brain is dura mater. Below the dura mater, you will have arachnoid matter, and below the arachnoid matter, the closest one to the brain is called as pia mater. All of them together are called as meninges. Whenever procedures are performed on meninges, which particular membrane you are operating on, or in between two membranes, there will be a space, and that space will be filled with a liquid called as cerebrospinal fluid. So whenever you are performing the procedures, you have to know in which space you are operating, or on which membrane you are dealing with. Only then you can assign your codes. So this first part of the brain is all dealing with the brain, the protective membranes, meninges, and the skull bones, which also protect your brain. So for all the procedures on this part will be listed into the first section of this chapter. The second section of the chapter is all about spinal cord. So whatever procedures are performed on spinal cord, the meninges covering the spinal cord, and the vertebral column. Few of the codes related to vertebral column we have already checked into the last class under musculoskeletal system. Certain vertebral procedures we have seen, but few procedures related to vertebrae are listed in here also, because vertebrae are going to protect your spinal cord. So under the section spinal cord, you will find the codes for that also. And then comes the third part of the chapter, that is all related to nerves, peripheral nerves. Okay, so first part is all related to brain and the protective membranes of the brain. The second part is related to spinal cord and protective membranes of the spinal cord. And the third part of the chapter is all related to the peripheral nerves. So whatever type of nerve it is, be it somatic, so under somatic it is further classified as sensory, motor, and everything. So all those nerves, and like autonomic nerves, whatever type of nerve you are going to operate on, the codes will be listed into last part of the chapter. When I'll explain the procedures related to brain, same procedures will be repeated under spinal cord. Same procedures will be repeated under peripheral nerves also. So pay attention to first part. The second part and third part is going to be the same. So first here, brain, meninges, and skull bones. The very first procedure listed for brain is injection, drainage, and aspiration procedure. Whenever you are going to perform any injection directly into the brain tissue or into the meninges or the spaces around the brain, anywhere you perform injection or you drain some fluid or you aspirate the fluid from the ventricles of the brain or from the spaces around the brain, if you do that, then the codes are listed here. When you need to assign the codes here, first thing you have to check is the location. Which part of the brain you are injecting or going to drain through or going to aspirate the fluid from. Is it any space you are doing the procedure in, or you are dealing directly with the brain tissue, or if it's brain tissue, then which part of the brain? That is what is you have to check. The second thing you will check is whether it is a diagnostic procedure or a therapeutic procedure. What is a diagnostic procedure? Say I'm just in the fluid because the brain is swollen and patient is getting fever and he is like having certain symptoms which I think are of infection around the brain. So I'm going to drain some cerebrospinal fluid. Maybe I'm taking it around the like whatever spaces around the brain or from the ventricles of the brain. I took out some fluid for doing the investigations whether there is any infection or not. So for laboratory testing, I have taken the fluid, then I call that procedure as drainage diagnostic procedure because I use that whatever drained fluid, I used it for diagnosing the patient. But say I drained the fluid around the brain because there was accumulation of the fluid around the brain which was causing pressure on the brain. So I wanted to release the pressure and that's why I drained the fluid around the brain. This time I drained fluid for therapeutic purpose. For the treatment, I did it. I did not do it for diagnosing some condition. I did it to treat the whatever intracranial pressure was increasing. To release that pressure, I just drained that fluid. So that is called as a therapeutic procedure. So in both the cases, I performed the procedure that is drainage. But the previous case, it was for diagnostic reason. The second case, it was for therapeutic reason. So whenever you are going to perform, be it injection, drainage, aspiration, you have to check, was it done for diagnostic reason or was it done for a therapeutic reason? And based on that, you have to choose the codes. So that is all about choosing the codes for this procedure, injection, drainage, or aspiration. You have to know the location and you have to know whether it is for diagnostic reason or was it for therapeutic reason. And based on that, you have to choose the codes. That was all about the first procedure. The second procedure is twist drill, burr hole, or trephine. This is not a procedure actually. These are all different devices. Twist drill, burr holes, trephines. These are certain devices which are used to create a opening into your skull bone. So whenever I need to operate on the brain, every time I'm not going to cut open the patient. I will create small openings. A very small hole is drilled into your skull bone, and through that hole, you can pass your surgical instruments or whatever required thing you can, like if you want to collect certain biopsy samples or drain some fluid or whatever, you can do through that. So, whenever I'm doing so, which device I'm going to use, first of all, you have to check. There are different devices to create these openings into the skull bones. Either you use a twist drill, it's like a drill what you use on your walls, similar way. It's used for drilling into your skull. So that is a twist drill. Similar way, these burr holes and trephines are there, which are similar devices, but these trephines usually are used to create a larger opening. With a drill, you can create a smaller opening. With a trephine, a little larger opening you can create. So that is what is first you have to check whether which of these devices is used to create the opening. The second thing again you have to check is the location where I am creating the opening. So whichever part of the brain I need to operate on, only near to that I will create the opening. So where exactly on the skull or which part of the brain where I am creating the opening, that you have to check. That is the location. The third thing what you are going to check is the reason. You are not unnecessarily going to create the opening into the skull bones. You have to have some reason to create the opening. So what you wanted to do by creating the opening? Was it some blood collection you want to drain that? So drainage of hematoma, or maybe to drain the cerebrospinal fluid, or maybe to collect the biopsy sample, or you created the opening to maybe just treat some part of the brain or perform injection or do some surgery. Why you have created the opening, that you have to find out, and based on these three things you will choose the course. First, check which device is used, then check what was the location to create the opening where you created it, and lastly you will check the reason to create that opening, and by matching these three things you will choose your codes for twist drills, burr hole, and trephine. After this procedure, you have got the next procedure, that is craniotomy and craniectomy. So what is this craniotomy and craniectomy? So cranium, it is nothing but your skull bones. They refer it as cranium. Okay. For the skull bones, when they are going to remove the part of a skull bone permanently, I removed a part of skull bone permanently. Maybe I wanted to do a surgery and there was excessive infection inside or swelling inside, and that's why I cannot reattach that piece of bone. Whatever I have removed, I have to just permanently remove it. In that case, it's called as craniectomy procedure. But sometimes you want to operate on your brain. For that, you need to cut open the skull bones. So you'll cut them open and then you do the surgery inside and then you are going to close it back. So when you close it back, so for time being, you have opened it and you are closing it back, then you call it as craniotomy. You remember I just mentioned the suffix, what we use usually for surgical procedure. Ectomy refers to removal and otomy refers to taking the incision and closing it back. So similar way here it is. But many times what happens is for a particular patient, you will see both the words together are listed for the patient. No one wants to remove the piece of skull bone permanently. No doctor would want that because then your brain is directly exposed. So that is why it's going to be, you have to take a lot of precautions for such patients, and that's why no one wants to remove it permanently. What the doctors will plan is they will cut open the skull, then they are going to do some procedure into the onto the brain. Once the procedure is done, they are going to reattach that piece of bone. So in the pre-operative notes, everywhere you will see they have mentioned craniotomy, craniotomy. They will perform craniotomy and then they are just going to close it back. But when the doctor cut open the patient, what the doctor found during surgery was like there is excessive swelling or infection or something is there for which the doctor cannot reattach that piece of bone. So earlier doctor has planned it as craniotomy, but he ended up doing a craniectomy for the patient. So in the post-operative notes, you will see everywhere craniectomy is written. So for that same patient, in the beginning you see craniotomy, in the end you see craniectomy. So what you are going to code for? When you are going to code for, you are going to code for the end result. What was the end result of the procedure? Whether they reattach that piece of bone or not. If they have reattached, then you code it as craniotomy. If they have not reattached that piece of bone, then you code it as craniectomy. So whatever in the end has happened that you have to code, for that you have to read through entire surgical note. Maybe in the beginning, if you saw craniotomy and you coded it for craniotomy, and in the end the doctor has done craniectomy, then it's wrong, whatever you have coded. So you have to read the entire surgical note from the pre-operative notes to the post-operative notes, and entire body of the surgical procedure you have to read, and then only you can decide. The second thing which you are going to check when you are coding for craniectomy or craniotomy procedure is again the location. Where exactly, which part of the bone I am removing. So skull bone is like a big portion. So where exactly, which part of the skull bone I am removing, that I have to check the location. The third thing I will again check is the reason why I am doing this craniectomy or craniotomy procedure. Was it to release the pressure on the brain? Was it to like treat the infection? Was it to remove the tumor? Or why you did that procedure? Basically, you have to match that and you have to code it. So these first three procedures were simple. First was injection, drainage, and aspiration, for which you will check that whether it was a diagnostic procedure or therapeutic, and the location you have to match and you code it. The second twist drill, burn hole, trephine, you will match three things, that is which device was used, where the opening is created, and why it was created. For craniectomy and craniotomy also, you'll match three things. Which one of these procedures was performed. Then you have to check the location, and finally you have to match the reason for doing the procedure, and then you will assign your codes. For understanding this craniectomy and craniotomy, I'll play a short video. In that video, they have explained about meninges also. Okay. So in the earlier video, they have not detailed about the meninges. So there are three meninges. In between the meninges, there will be a space filled with cerebrospinal fluid. So that is, I am playing this because when we are going to go to spinal cord and other further procedures, you need to know these all spaces and how they are arranged. Okay, so I'm playing that video. Pay attention to that. Both the things, that is the information about the meninges and the information about craniectomy and craniotomy, both they have explained in here. And you will see the openings, what they create in this procedure on the skull bone. That is, the device they use is a burr hole. Okay. So I told you different are there.
Your doctor may recommend a craniotomy or craniectomy procedure to treat a number of different brain diseases, injuries, or conditions. Your skull is made of bone and serves as a hard protective covering for your brain. Just inside your skull, 3 layers of tissue, called meninges, surround your brain. The thick outermost layer is the dura mater. The middle tissue layer is the arachnoid mater. And the innermost layer is the pia mater. Between the arachnoid mater and the pia mater is the subarachnoid space, which contains blood vessels and a clear fluid called cerebrospinal fluid. Blood vessels, called bridging veins, connect the surface of your brain with the dura mater. Other blood vessels, called cerebral arteries, bring blood to your brain. Inside your skull, normal brain function requires a delicate balance of pressure between the blood in your blood vessels, the cerebrospinal fluid that surrounds your brain, and your brain tissue. This is called normal intracranial pressure. Increased intracranial pressure may result from brain tumors, head injuries, problems with your blood vessels, or infections in your brain or spinal cord. These conditions put pressure on your brain and may cause it to swell or change shape inside your skull, which can lead to serious brain injury. Your doctor may recommend a craniotomy to remove abnormal brain tissue, such as a brain tumor, a sample of tissue by biopsy, a blood clot called a hematoma, excess cerebrospinal fluid, or pus from an infection called an abscess. A craniotomy may also be done to relieve brain swelling, stop bleeding called a hemorrhage, repair abnormal blood vessels, repair skull fractures, or repair damaged meninges. Finally, a craniotomy may also be done to treat brain conditions such as epilepsy, deliver medication to your brain, or implant a medical device such as a deep brain stimulator. The most common reason for a craniotomy is to remove a brain tumor. Before your procedure, you will be given general anesthesia to make you unconscious and pain-free. The skin on your scalp will be shaved over the location of the tumor. To begin, your surgeon will make an incision in your scalp. 1 or more small holes will be made in your skull. Then your surgeon will connect the holes to create a circular piece of bone called a bone flap and remove it. Your surgeon will make an incision in the dura mater to expose your brain. Then your tumor will be removed. The incision in the dura mater will be closed with sutures. Your surgeon will reattach the bone flap with metal plates and screws that will remain in your skull for life. You may have a variation on a craniotomy called a craniectomy if your brain is very swollen or your skull is infected. Your surgeon may delay reattaching the bone flap until a later procedure to allow time for the swelling to go down. At the end of either a craniotomy or a craniectomy, your scalp incision will be closed with staples, and your head will be wrapped in bandages. If you had a craniectomy, you will have another procedure called a cranioplasty at a later date after the swelling goes down. At that time, your surgeon will reattach your bone flap with metal plates and screws. Then close the skin incision with staples. After either procedure, you will stay in the hospital for several days. Your caregiver will check your brain function by asking you questions and shining a light in your eyes. You may be given medication to prevent complications.
Okay. So that was both the procedures, how they are different, that is explained, and the meninges also were carefully explained into that video. We will need this in the upcoming procedures. So here all these codes for craniectomy, craniotomy, multiple codes are there. Whatever things I asked you to match, you will match and you will choose your codes. That was craniotomy, craniectomy. The next procedure listed is surgery on the skull base. So surgery on the skull base, it is done into 3 steps. Whenever you need to perform the surgery on the skull base, you have to perform an approach. Like we just discussed into musculoskeletal system for vertebral column. Wherever I need to operate on the spinal cord, I just have to check from which side of the body the doctor is going to take the incision to reach out to that surgical location. So that is called as an approach. For brain also, you have to know where is the approach, which part of the brain you cut open. Not brain, but the skull bones, where you make the opening into. That is divided into 3 parts. That is anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So all your approach procedure, where you make the approach from anterior side or in the middle portion or in the posterior part of the skull bones, where you make the approach. That is first step of the procedure. Usually for doing neurosurgeries, you will have 2 doctors involved, one orthopedic surgeon and the other neurosurgeon. Both will be involved. Orthopedic surgeon will create the opening so that the neurosurgeon can operate on the brain. So once the opening is created, approach is usually made by the orthopedic surgeon, and then the neurosurgeon is going to operate on the brain. So which part of the brain you are going to operate on again? So anterior part of the brain, middle portion of the brain, posterior part of the brain, where you are going to perform that procedure, that is called as a definitive procedure. Once the definitive procedure is done, the third step is repair. Whatever you have cut open, you have to close it back, everything. So for repair, again, there will be a separate code available. For coding the surgery on skull base, you have to use 3 codes in all. First code for the approach, the second code for the definitive procedure, and the third code for the repair. If different doctors are involved, then you have to check which doctor has performed which part of the surgery, and for that you will assign that particular code. But if all the steps of the surgery are done by one single physician, then you will use all different code under his name, and you will use modifier 51. Remember modifier 51? What is it? Sorry?
Pension service.
Same in sequence.
Multiple
Multiple procedures are
Multiple add-ons.
Yeah, it is for multiple
Okay.
procedure.
Yes.
Procedure.
Huh?
Or multiple procedure.
Yes, multiple procedures, though they are operating on the brain, but all the steps of the surgery are counted as different procedure. And that's why you code all the steps of the surgery with modifier 51. Whenever you do different surgeries in the same operative session through same incision and a same physician is involved, then you use 51. If different physicians are involved, different parts of the body and different incisions, then you use 59. So here, through the same opening, I'm doing everything. I'm creating an approach, then I'm operating on the brain, and then I'm fixing everything, repairing everything later on. So through the same opening, through same incision, same physician is operating. So I code each step with modifier 51. So here, whatever I just said, that all they have explained here, the definitions are given. What is approach procedure? What is definitive procedure? What is repair procedure? That all definitions are given here. And further, if you go down, the last line, last paragraph on that page, if you see, they have mentioned about if one surgeon performs more than one procedure, that is approach procedure and definitive procedure, then both codes are reported by adding modifier 51 to the secondary additional procedure. Okay, whatever I just said is all that written here into the guidelines. Now coming to the codes, if you see all your codes, they have already classified the codes for the different parts of the surgery. The first part what they have mentioned is approach procedure. Under approach procedure also I told you there will be 3 types of approach, from the anterior side, middle or posterior side. So whether you are creating the approach into the anterior cranial fossa, middle cranial fossa or posterior cranial fossa, you have to check that. You will go to that code range, then you have to match the entire description, because all these codes are descriptive from where you are creating the opening, like how you are doing that. Like if it's approach, then I'm just completely cutting open the skull bone, or I am just first drilling the holes, and then like through the maybe holes I'm operating, or maybe I'm connecting those holes and removing that part of bone, and whatever I'm doing. Sometimes to brain, you can reach out through your nose also. From the nose, the doctor can insert the surgical instruments, and he can operate on the front part of the brain. So these procedures also are possible sometimes through the eyes. Like if it's accidental case, already the frontal part of the brain is or your face is damaged. So through orbits, you can reach out to the brain. So there are different ways how you can reach out to the brain. So what was the approach? Anterior or middle cranial fossa or posterior cranial fossa? Whether it was a closed procedure, was it an open procedure, that all you have to match the description, and then you can assign your codes. The codes are self-explanatory and there are no guidelines for that. Next is definitive procedure. Definitive procedure is again where exactly on the brain I am operating. Maybe I have created the opening onto the front side of the brain, but I am operating on the middle part of the brain. It can happen. So it's not necessary that I created the approach on the anterior part. So anterior approach, but the procedure is done on the middle cranial fossa. It can happen. So it is not necessary to match where you operate and where the approach was made. It can be different. So you have to check that also. So once the approach is done, definitive procedure on which part of the brain it is done, again it is classified into base of anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. You have to check, go to that code range, match the description, and you can choose the codes. Again, no specific guidelines. Lastly, repair procedure. And the repair procedure, only 2 codes are there. So how the repair was done, you have to match that description and you have to assign the code. That was all about the surgery on the skull base, which is very similar to what we saw for the vertebral column. You have to check the approach, you have to check where the definitive procedure is done and repair, and assign the codes. Coming to the next procedure, that is endovascular therapy. What is the endovascular therapy? By endovascular therapy, they mean either you are doing angioplasty or stent placement or atherectomy or sometimes thrombectomy or embolectomy. Whatever procedures you do through the vessel, you are going to like perform some procedure on the vessel, and you're not going to cut open that entire vessel. Maybe you pass a guide wire, you want to pass some scope into the vessel and you treat it. So what is embolus? Embolus is nothing but a air bubble inside the vessel. So we cannot have the air bubbles into the major vessels, otherwise they will block the vessel and the blood flow to the respective part of the body. So if there is any vessel which is supplying blood to your brain and there is an embolus, then the blood supply will be blocked to that part of the brain. I need to get that embolus removed. So removal of this embolus is called as embolectomy procedure. Thrombus is the blood clot inside the vessel. Inside your vessels, you never will have blood clots. Only when the blood is flowing out of the body, blood will clot. Inside your body, it should not clot actually. So that is what is, if there is a clot into the vessel, that clot can block the vessel, and again the blood supply to the part of the brain can be stopped because of that clot, and that is why you have to remove it. When you remove that thrombus, the procedure of removal of the thrombus is called as thrombectomy procedure. For that, sometimes I use a suction device to get it removed. So I just pass a guide wire. On the guide wire, there will be a suction device mounted. That suction device will suck up that whatever blood clot is there, and it will be removed. So various different procedures are there to get that removed. So that is one of the things I explained. Then angioplasty. What is angioplasty? Angioplasty, most of you must be knowing. They will have a guide wire. On the guide wire, there will be a balloon mounted, a deflated balloon. And then wherever the block is to the blood, I'm going to push that guide wire in that area, and then I'm going to inflate and deflate that balloon. So with the inflation and deflation of the balloon, the vessel will open. Once the vessel is open, so blood will flow freely from there. That is called as angioplasty. But sometimes it happens, like say there is fat deposition inside the vessel, and that's why the vessel is blocked, or the vessel is into spasm, and that's why the blood is not flowing. So I might do angioplasty, but later on the vessel will collapse again after doing angioplasty. So if there is a chance of collapse, then what I'll do after angioplasty, I'll place a stent inside. Stent is nothing but a spring like a metallic structure, which you are going to place it inside the vessel to keep that vessel wide open entire time. So that is a stent placement can be performed. If not, sometimes I need to perform atherectomy. Atherectomy is when the vessel is blocked with a fat deposition. There is fat deposition inside the vessel. So what I do is I remove that, or whatever fat deposition, I'm going to get it removed. That is called as atherectomy. So whatever procedure you do, all these procedures together are called as endovascular therapies. Whenever you are going to code for endovascular therapies, first of all, you have to decide which one of this treatment is done. Was it angioplasty? Was it stent placement? Was it atherectomy, thrombectomy, embolectomy? Which procedure doctor did? Doctor might do combination of two procedures also, or three procedures together also. Like I can do angioplasty along with stent placement, or atherectomy along with stent placement. I can perform combination of two procedures or one procedure at a time. If combination of the procedures are done, then there will be codes mentioning all those procedures together. So always you have to check which all procedures are done. Then the second thing, you have to check on which vessel you are performing the procedure. Like there are a lot of vessels in your body. Your vessels are classified into two basic types: arteries and veins. Arteries will always carry oxygenated blood away from the heart, so towards the organ, and veins will carry deoxygenated blood from the organ back to the heart. So which vessel is blocked? Was it an artery, or it is a vein? Which vessel is blocked? You have to check, and exactly the name of the vessel you have to also know. If it's an artery, then which artery? A cerebral artery, or a carotid artery, or maybe occipital artery, and so on. So all these vessels related to brain, which one of these is exactly blocked or being treated? That location you have to know. The third thing you will check is the order of the vessel, and whether, if say I'm treating only one single vessel at a time, no issues, I can code it. But if I'm treating two vessels or three vessels together in the same operative session, then all these vessels are into the same territory or different territory. I have to make it out. So what is a territory? Territory is basically when, okay, for to understand territories, I want you to open your appendix L. Open your appendix L. It will be mostly in part 2. Okay. Here it is, page number 994. Okay, just go ahead in that appendix. Appendix L, it is for vascular families. In the appendix L, just open on this page, that is page number 998. There. Found it? So here if you see, they have vascular families or vascular territories. Territory, family, synonym words are there. So this appendix L you have to use whenever you code for endovascular therapies. We are checking this into nervous system, but when we are going to go and check the codes into cardiovascular system, you will have lot of codes for endovascular therapies, because all the vessels are part of your circulatory system. So you will have codes for endovascular therapies listed under cardiovascular system also. I'll not explain the same thing under cardiovascular system. Okay, so pay attention now. So vascular families are classified into arterial vascular families and venous vascular families. So whether I am dealing with the artery or dealing with a vein, based on that the families are classified. So here we will check arterial vascular families, same way it will be for veins. If you see arteries, the major artery which originates into your heart is called as aorta. Okay, aorta is the major vessel which originates into the heart, and this aorta is then going to arch into your chest cavity. So from here it will arch down. This part of the aorta is called as arch of aorta. This arch of aorta, when it goes down further, it descends down into your chest cavity. When it is going to go down, it is called as, this particular part of the aorta is called as descending thoracic aorta. Then this aorta, descending thoracic aorta, further goes down, and when it passes below the level of the diaphragm. Diaphragm is nothing but a membrane which separates your chest from your abdomen. In the middle, you will have that membrane called diaphragm. So when this aorta passes below the level of the diaphragm, you will call it as abdominal aorta. Abdominal aorta further goes down into your body, and when it goes below the level of your kidney as in, like, specifically from the aorta, various branches will be there, because one single vessel cannot supply blood everywhere. So this vessel is going to branch out multiple times in your body to supply blood everywhere. So here, when this particular branch arises from aorta called renal arteries, that is for your kidneys. Below the level of this renal arteries, this aorta continues, and this is called as infrarenal aorta thereafter. So abdominal aorta further continues down below the level of the kidney as infrarenal aorta. This infrarenal aorta further goes down, and then it is going to branch into two to supply blood to your lower extremity, to right leg and left leg. It will branch it down into two, right and left. When it branches down, these are called as iliac arteries. Common iliac arteries, right and left common iliac arteries. And further, it will go down and again branches will be there, but that we will check later on. So this is the course of aorta. Aorta originates into your heart. It arches down into the chest and then continues down as a descending thoracic aorta. Descending thoracic aorta continues below the level of the diaphragm as abdominal aorta. Abdominal aorta further goes down below the level of the kidney called infrarenal aorta. Infrarenal aorta further divides into two, right and left common iliac arteries. I explained this because when we are going to go into the cardiovascular system, there also you have to know this entire course of aorta. Your codes will be classified so. Now this aorta, as I said, it's a major artery. It carries blood, oxygenated blood to all different parts of the body. But one single vessel cannot supply everywhere. So it has to give out branches. And all different branches will have their own names. This branching when happens for the very first time. So say from the aorta, the branches arise directly from aorta. If you've seen here, this arch of aorta, the branching is happening here. Three branches are arising here. When the rise directly from aorta, whichever branch it is called as a first order vessel because branching has happened for the very first time. Then, if you follow this particular vessel, say this brachiocephalic artery, this brachiocephalic artery is going further in your body, and then again it is dividing into two. So, when the branching has happened again, second time. So, whenever branching happens second time, I call these vessels as second order vessels. Now, if you follow, okay, see in here, same thing I do have with the color codes. Say this is the arch of aorta. Arch of aorta, first time the branches arise from arch of aorta, that is your brachiocephalic artery, left common carotid, left subclavian. These are called as first order vessels, whatever you see in yellow color here. Now I am following this first order vessel, that is brachiocephalic artery. It is going further in your body, divides into two. That is right common carotid and right subclavian. These are which are in green color. These are called as second order vessels because branching has happened second time. Then if you go further, follow this right common carotid artery. It is going further in the body and it is again dividing into two. When it divides third time, I call these vessels as third order vessels. So that is your right external carotid and right internal carotid. These are called as third order vessels. These vessels will go further in the body, again they will divide. So whatever branching happens after the third order is called as beyond third order. So maybe fourth time, fifth time, sixth time branching is happening. I will not count thereafter. I will say everything thereafter as beyond third order. So that is how you decide the order of the vessel. When the vessel arises directly from aorta, it's first order vessel. When this vessel goes further, divides second time, second order vessel. When it again goes further, branches again third time, then it's a third order vessel, and whatever after that is beyond third order. Once I decide the order of the vessel, how do I decide whether they belong to same family or not? To decide whether they belong to same family or not is I have to check whether the vessel is originating from the same first order vessel or not. Like you have your family tree, your grandparents, then your parents and your uncle, aunts, everything. Then the next level will be you, your siblings. Then on the next level, maybe your kids, their like the cousins and everything. So all this together, they belong to same family. Okay, their family name will be same. Similar way here also. Now, if say I want to decide whether this particular vessel, right internal carotid and say right internal mammary, these vessels belong to same family or not. How do I decide? I have to check which vessel they originate from. So right internal carotid, when I just go down, I see it is originating from right common carotid. Right common carotid is further originating from this vessel, that is brachiocephalic. For internal mammary, I'll do the same thing. This is a third order vessel. Internal mammary is originating from right subclavian. Right subclavian is further originating from brachiocephalic. So both the vessels basically originate from the same first order vessel, that is brachiocephalic. Then I say they belong to same family. Okay. So if I have to say decide now whether this left internal mammary and right internal mammary, whether they belong to same family or not. So in that case, when I just go further to the first order vessel, I will check, I will see right internal mammary originates from brachiocephalic, but left internal mammary originates from left subclavian, that is a different vessel. So I say both the vessels belong to different families. Okay, so always you have to go down till the first order vessel. And when you find whether the vessels, all the vessels are originating from the same first order vessel, then you say they belong to same family or same territory. If they are originating from a different first order vessel, then you have to say they belong to different families or different territories. This is made simple into this diagram. If you see, if you go back to your code book, here they have color coding. This is the black and white book what you have, but in the original book it will be colorful diagram. So you can make out which is the first order vessel for every first order, second order, third order vessels. They will have different colors. So you can make it out. So that is all explained in here, how to decide the order of the vessel. Here the color codes or everything they have mentioned. So which color is used for first order, second order, third order, beyond third order, all different colors will be there. So that was all about deciding the order of the vessel as well as the family of the vessel. If you are not comfortable using this diagram, then you can go back and check the first page of Appendix L. First page of Appendix L, it is for vascular family. The first thing listed is arterial vascular family. I told you there are two types of families, arterial and venous. So for the arterial vascular family, below that if you see what is written first, thoracic aorta. So I told you aorta originates and then it goes down as descending thoracic aorta. So thoracic aorta is going to give out branches. So whatever branches come out for the very first time from aorta, these are all listed under first order. So this column, if you see, all the branches which originate from aorta are listed in this column as first order vessel. Whatever I just had on the diagram, you will see the same thing. So here is the brachiocephalic, which is a first order vessel. Then we followed that brachiocephalic, which divides into two, again, major branches, that is right common carotid and right subclavian, which are listed here under second order vessel because the branching has happened for the second time. Now, if you go further, if you follow the second order vessel, that is right common carotid, it is going further in the body and dividing again into two. When the division happens for the third time, the vessels are listed under third order vessel. And then further, if you follow this right internal carotid, which gives out multiple more branches, all the branches are listed beyond third order. So this is a tree diagrammatic representation here. It is very easy to follow, so you can make it out. You have to go one level down and check which vessel they originate from. So say if I have to decide right ophthalmic artery and right facial artery, whether they belong to same family or not, I just have to keep going down one level. So right ophthalmic originates from right internal carotid, which originates from right common carotid, which originates from brachiocephalic. So it belongs to the family brachiocephalic, right ophthalmic. Then I check right facial. Right facial originates from right external carotid, which originates from right common carotid, which again originates from brachiocephalic. So it also belongs to brachiocephalic family. So when I need to see both these vessels, right ophthalmic and right facial, they originate both from brachiocephalic. So I say they belong to the same family or same territory. Whenever you need to decide the territories, you have to make use of Appendix L. Now, if you follow this thoracic aorta, the thoracic aorta, if you just see, that goes on as on the second page, this thoracic aorta continues, and on the next page, you will see there is a dotted line in the middle of the page which represents diaphragm. I told you when aorta goes below the level of the diaphragm, it is called as abdominal aorta. So same way it is listed here as abdominal aorta. So abdominal aorta also is going to give out branches. So all this is given here into the diagrammatic representation. You just can follow this. It is easy to follow to decide the order of the vessel as well as to decide the territory of any vessel. Now going back to your codes. If you have those codes open under endovascular therapy, check this code so I can explain. 61640. There. So the code 61640, what is the description of the code? Balloon dilatation of intracranial vasospasm percutaneous initial vessel. What is balloon dilatation? I told you balloon dilatation is nothing but angioplasty. So when the doctor is performing angioplasty for any vasospasm, for any vessel supplying blood to your brain, then if the vessel is into spasm, to open the spasm, if you are doing angioplasty into one single vessel, initial vessel, you use this code 61640. But say the multiple vessels are into spasm, 2, 3, 4 vessels are into spasm. I need to open them all. When I am doing this procedure, angioplasty in all the vessels in the same operative session, then I have to use the add-on codes for additional vessels. And whether the additional vessels belong to same territory or different territory, I have to make it out. So first code, if you see this add-on code 61641, it is the code for each additional vessel in same territory. If the additional vessel belongs to same territory, then I use this add-on code. But if the additional vessel belongs to different territory, then I have to use the next add-on code 61642. Okay. Now, can you get me the codes for angioplasty performed into right occipital and right facial arteries? Angioplasty done into right facial and right occipital arteries. So first you will go use your appendix L, decide whether these vessels, they are intracranial vessels. That obviously these are intracranial vessels, and then you have to check whether they belong to same territory or different territory, and then you assign your codes. So use your appendix L and get me the codes.
61641.
Okay. Only 641? Only one code you'll use. We do not use add-on code alone, right?
No. After the first code, 61640, then 61641.
Yes. Okay. So you will use two codes. Say I treat my occipital artery as my first vessel. So for the initial vessel, when angioplasty is performed, 61640 is the code. So I used it. Then I have to use a add-on code depending on whether the next vessel, that is right facial, I said. So right facial, whether it belongs to same territory or not, that you have to decide. So for that, if you open your appendix L, into appendix L, check occipital, right occipital, where it is. Okay, here. Right occipital is here. And for the right occipital, it belongs to the family brachiocephalic. And then I said right facial. So right facial, it also belongs to the same family brachiocephalic. So they belong to same families. So when they belong to same families, I have to choose a add-on code which will mention for the same territory. So I'll use a add-on code 61641. That is each additional vessel into same territory. Is that fine? Any confusion in deciding the order of the vessel or deciding the territory of the vessel? Because I will not be explaining the same thing when we will go to cardiovascular system, okay? You will again need this when we will be into cardiovascular system. Fine? Okay. So that was all about coding endovascular therapies. Be it any endovascular therapy into nervous system or cardiovascular system, same guidelines will be there. First, you have to check what is the order of the vessel you are treating and whether the vessels belong to same family or different families. You have to check that. According to that, you have to assign your codes. Before assigning the codes, always check which treatment they do, because under endovascular therapy, you can have angioplasty, stent placement, atherectomy, embolectomy, thrombectomy. So what exactly, which exact procedure they are performing, that code range you have to find out. And then you have to choose the codes for single vessel or additional vessels based on the appendix L, same territory, different territory. You have to apply and you have to choose the codes. Multiple codes are there for this endovascular therapies. Guidelines are same. Coming to the next procedure, surgery for aneurysm or arteriovenous malformation or vascular disease. Whenever your patient is suffering from any of this condition, be it malformation, be it aneurysm. So aneurysm, all of you understand? Aneurysm is nothing but a bulge into a vessel. Say this vessel always should be intact like this. But sometimes say there is a bulge into a vessel like this, or the bulge can be like this. So whatever is when the vessel wall, it becomes weak, it will bulge. So when the vessel wall bulges out, there is a chance that already the vessel wall is thin in that area. That's why it's dilating. So there is a chance it will rupture. If it ruptures, then the patient will bleed inside. And because of the internal bleeding, there are chances your patient might suffer complications or life-threatening conditions. So whenever there is a dilatation into the vessel, it's called as aneurysm. You need to treat it. How you are going to treat it? Sometimes what I do, I remove the part of the vessel which is dilated. I remove that part and instead I use a graft. Some prosthetic grafts are available, or sometimes I use some healthy vessel from the patient's body, from some other part of the body. I take it up and I graft it here. So that I can do. Sometimes what I do is there is a device like what you can say, a rubber band compression device is there. It's like a elastic band. So that band I'm going to apply over the vessel wherever it is dilated. So that is another treatment. Or sometimes like the aneurysm is in this way, then what I do is I just clamp it here. I use a clip or some mechanical device is used to just block that particular dilated portion of the vessel. So bleeding will not happen and the vessel will remain intact and blood will flow with the same force. Otherwise, if dilatation is there, the blood flow in that area is going to be slow. And as the blood goes stagnant there are chances of formation of clots and other complications. So you cannot let these aneurysms in the body. You have to treat them. Whenever you are treating, first of all, you have to check where that aneurysm is located, which vessel. That in particular vessel, which vessel is dilated or where the aneurysm is located, that you have to check, and based on the location you assign the course. Whatever is the treatment, whether you treat it by graft or whether you treat it by some elastic bands or you treat it by using a clip or other some device, doesn't matter where the aneurysm is located. You have to check that based on the location you assign your course. So it's simple. Treatment of aneurysms or any malformations into the vessel are there, you are going to treat them just by the location you assign the course. After this aneurysm treatment, you do have the next treatment listed is stereotaxis, and then there is another stereotactic radiosurgery. Whenever there is a abnormal tissue or abnormal growth into your brain or some diseased tissue is there, you prefer not to remove, but from outside you will apply some radiation to burn it out. Usually we will not cut open brain every time or the skull bones every time you do not expose your brain. So what you do is you are going to remove it from outside by application of the radiation, or you just burn it off. Say this is brain and on the brain this is the diseased tissue. So what I'll do is I will apply radiation to this entire tissue to burn it off. Then I call it as stereotaxis, a concentrated radiation provided to the diseased tissue so as to burn that tissue off. It is called as stereotaxis. Stereotactic radiosurgery, on the other hand, say this is your brain, and on the brain there is a overgrowth like this. This is a tumor like this. So when I need to treat it, I'm not going to burn the entire diseased tissue this time. What I'll do is I will apply radiation only to the stalk of the tissue. Wherever it is attached to the brain, only to that part I will apply the radiation. So the diseased tissue will separate from the rest of the healthy tissue. And when I do that separation, I call it as stereotactic radiosurgery. By applying the radiation, I have separated the diseased tissue from the healthy tissue. So I call it as a stereotactic radiosurgery. Whatever is the treatment, you just have to check whether they applied stereotaxis or stereotactic radiosurgery. Go to the respective part and then you assign your codes. The codes are self-explanatory. There are few guidelines, but I'll discuss those guidelines with the radiotherapy. Under radiology chapter, there will be codes for radiotherapy. In there, we will discuss the more guidelines for stereotaxis and stereotactic radiosurgeries. For now, just understand these are two different treatments. Whichever is applied, you are going to go read the entire description of the code, match with your patient's record, and you are going to choose the code. After this radiosurgeries, you have got the next procedure, that is a neurostimulator. Neurostimulator is, okay, it is a device. This device has got two parts. One is a battery, another part to the device is an electrode. If you see the diagram in here, they have mentioned this this particular into the diagram. You see this circular part of the device. It is called as a pulse generator, or it is also called as a battery. Battery or pulse generator is one and the same thing. It's a synonym word. Now this battery is connected to this long wire-like structure which is placed near to your brain. So this particular part, wire-like part, is called as an electrode, or you call it as a lead. Lead or electrode, these are synonym words. whenever my patients are suffering from, say, suicidal ideation, or say epilepsy, or there is insomnia, or maybe some psychiatric illness is there, you prefer to insert these neurostimulators into the body to suppress some part of the brain or to stimulate some part of the brain. So when we are going to insert it, I just have to do a procedure, surgery. So I'll insert the electrode as well as the battery. And then once you connect that electrode to the battery, it will be functional. So where you want to keep it, that you decide which part of the brain you want to deal with. Only there you will place the end of the electrode. For that, sometimes I do a open procedure. I cut open the entire skull bone and I place it there. Sometimes I don't have to cut open, but maybe I create small opening like a burr hole, twist drill, something I do, and then I insert it from there. So how I'm going to insert it? For insertion, there will be separate codes. Now say I have inserted this neurostimulator into the patient's body, but now he is feeling fine. He is all well. He doesn't need that neurostimulator anymore. Then what I have to do? I have to get it removed. So for removal, another procedure will be done. So for removal, separate codes will be there. So what you are going to do with that neurostimulator, whether you insert it, you remove it, sometimes say the batteries are discharged. If the batteries are discharged, the electrodes will not function. So I need to replace the batteries. When I need to replace the batteries, I have to take out the old ones and insert the new ones in there. So when I am replacing the battery, for replacement of the battery, maybe different codes, replacement of electrode, different codes, or sometimes some damage has happened, some leak is there or something into the battery. I need to repair it. Whatever the old batteries, because this new devices will be expensive. So I will prefer to repair the old one only. Whatever damage has happened, I'll repair it. So what I'm doing with the neurostimulator, you have to check that. Insertion, you are performing removal, replacement, repair of the device, what you are doing. Apart from that, you are going to check whether you are dealing with the entire device. Maybe when I'm inserting, I'll insert both electrodes as well as the batteries. If I'm just inserting the electrode, not connecting with the batteries, of no use because it will not function. So I'm inserting the entire device. But say when it's time for removal, say I want to remove the old batteries and insert the new ones. So it's replacement basically, but you will have two codes, one for the removal of the old battery, the other code for the insertion of the new battery. So you just have to check only with the part of the device you're dealing or with the entire device you're dealing. Based on that, your codes will be separate. So if you see the very first code in here, 61850, it is the code for implantation. Implantation when you insert the device into the patient's body. So they will mention whether they are inserting the entire device or they are inserting only electrodes or they are inserting only batteries. For everything, a separate code will be available. So this is the code when you do insert this particular electrode by using a twist drill or burr hole. But the next code, if you see, if you are inserting that same thing, you are inserting the neurostimulator electrode, but this time I'm inserting by craniectomy or craniotomy procedure. So how I insert it? By open procedure, by burr holes, twist drill. Based on that, all implantation codes will be there. These are all different codes. Then if you go down and check the code 61880 onwards, you will have codes for removal. When I need to remove the device, I do have separate codes. If you see 61885, this is the code for replacement. Replacement of the entire device or replacement of only the batteries or the electrodes, you have to check that. Then further, if you go down, there will be codes for again a revision of the revision or removal and so on. So all these different codes are there for the device. You have to check what the doctor is doing with the device and accordingly you have to code it. Next, you have repair codes. So repair, exactly brain tissue, if it is damaged, I cannot perform repair of the brain tissue. But the meninges over the brain are damaged or the skull bones are damaged, then I can repair them. So all these repair codes are there listed into the last part of this, the section brain. We are checking the first part of the chapter, nervous system, brain and related structures. So we discussed all different procedures on brain, starting from your injection, drainage, aspiration, then your twist drills, burr holes, strip-ins, then your craniectomy, surgery on skull base, then endovascular therapies, then further there's neurostimulators and everything. So all these procedures we are discussing for brain and meninges. So this is the repair procedure. Codes are direct, no specific guidelines for that. Next, last procedure is cerebrospinal fluid shunt. So CSF shunt, it is basically again a surgical procedure where you insert a catheter. A small catheter you are going to insert into some of the spaces around the brain or into the ventricles of the brain. What happens when this cerebrospinal fluid is there around your brain and it's completely circulating? It is providing nutrition to your brain tissue as well as it is maintaining a specific pressure around your brain. If there is a blockage to the circulation of the cerebrospinal fluid, then what will happen? The fluid will accumulate around the brain. It will cause added pressure on your brain tissue. So with the increased pressure, your brain will damage. So you have to release the pressure. For that, usually you use the shunt. This shunt is a catheter. One end of the catheter, I place it wherever the blockage is. I will just keep one end of the catheter. The other end of the catheter, I will usually you place it somewhere into the body, either in like most commonly into the abdomen. I'll leave the other end open into the abdomen. So as and when the pressure will build up around the brain, with the increased pressure, the fluid will flow into the catheter and drained into the abdomen. From the abdomen, it will be absorbed or like whatever it is thrown out of the body, excreted and everything. So that is how it is. Shunt is placed. This shunt will have one valve to prevent the backflow of the fluid. So fluid can flow only in one direction. This shunt, whenever I am going to place, again I have to check what is being done with the shunt, whether I am inserting it, removing it, replacing some part of the shunt, or I am going to get it repaired. What I am doing with the shunt, you have to check that. An exact location of the shunt you have to check, because when I place it near to the brain, in where exactly near to which part of the brain I am placing it, into the subarachnoid space, into the subdural space, into some ventricle, first ventricle, third ventricle, which ventricle of the brain. So where exactly I have placed it and what I'm doing with the shunt, you have to check that, match with the code description and you choose your codes. The codes will be simple. So that was all about the first part of the chapter related to brain, meninges and skull bones. Any doubts? Okay. So we'll
No,
move
ma'am.
on to the second part of the chapter. That is related to spine and spinal cord. So spine means your vertebral column and the spinal cord is a part of your nervous system. So spinal cord is protected by the spine and over that again you are going to have meninges. Whenever you are coding any procedure, like say neurostimulator, I want to code for. Neurostimulator will be listed under brain. It will be again listed under spinal cord. It will be listed again under the last part of the chapter, that is under peripheral nerves. So say I am coding for the procedure neurostimulator. I have to check whether I am doing it for brain. Then I go to the first part of the chapter. If I am doing it for the spinal cord, I have to come down to the second part of the chapter. Because everywhere you will see that heading neurostimulator, neurostimulator, neurostimulator. Three times it will be listed. So always whenever you code any procedure, check whether you are doing it on brain or on spinal cord or on peripheral nerves. According to that, you go to the respective area and then you start searching for your codes. So here under spine and spinal cord, you have the very first procedure again, injection, drainage and aspiration like we saw for brain. I told you there, when you code for injection or drainage or aspiration, you have to check for two things. One is the location where I am performing the procedure. The second thing is whether the procedure is therapeutic or diagnostic. Same things you will check here also, but here for location, when you check the location. For brain, these are the wider portions of the brain. So I just can find out the location very easily. But for spinal cord, you have to check. Spinal cord extends from the base of your skull till the tailbone. And it passes through all different portions of the body and every portion of the spinal cord, like your vertebrae are classified into cervical, thoracic, lumbar and sacral and so on. Same way your spinal cord is also divided into different parts. So where exactly I'm doing this procedure. If I'm performing an injection into the cervical region, into the thoracic region, into lumbar region, that I have to check by location. Or further thing, by location, you have to check when I perform the injection. If I'm performing it into the spinal spaces, then I'm doing it into the space between dura mater and arachnoid mater, then I call it as a subdural injection. Usually, when patients are about to undergo surgeries or they want to receive anesthesia, you will inject into the spinal spaces. The spinal spaces also, the injections are classified as your, what you can say, spinal injections or epidural injections. What is a epidural injection? When I inject the medication into the space between dura mater and arachnoid mater, I call it as epidural injection. When I push my needle further down below arachnoid mater, so I'm pushing it down below the arachnoid mater. So between arachnoid mater and pia mater, I'm injecting, then I call it as spinal injection. So where you are injecting, based on that, again, the codes will be classified, whether it was a spinal injection or epidural, whether it is into cervical region, thoracic region, lumbar or sacral region, that also you have to check. Furthermore, you have to check one thing is, like I said, when my patient needs to receive anesthesia, I perform the spinal injections. If I am injecting the anesthetic, I will not use any of the codes listed in here. If it's anesthesia, the reason for injecting into the spinal spaces is anesthesia. Anesthetic is injected. We have a separate chapter, anesthesia. We will use codes from the chapter anesthesia for those injections. But if at all, apart from anesthetic, I'm injecting some other medication for treatment, or maybe usually after surgeries for pain relief, you will inject this painkillers, that is analgesic medications are injected into the spinal spaces for pain relief. So that is when it is done, you can use this codes. Analgesics, fine. Or any other medication, you can use this codes. But if it is a anesthetic injection performed into the spinal spaces, go and use your anesthesia codes, not the codes listed here. Okay. This is what is you will check when you're coding for injection, drainage and aspiration procedures for vertebral column. So what you will check is, what was the reason to do the procedure, diagnostic or therapeutic. Then you have to check the location. By location, you have to check whether cervical, thoracic, lumbar region, and you have to check whether epidural or spinal. And further, you will check anesthetic or analgesic. If it's anesthetic, do not use the codes. Go back to anesthesia chapter. That was all about this procedure, injection, drainage, and aspiration. Multiple codes are there. Based on these two things, you have to choose the codes. Next one you have after injection procedure is decompression directly. Okay, you do have this percutaneous decompression of neural elements. Decompression is whenever there is a pressure on your spinal cord. Maybe spinal cord is swollen, or there is the cerebrospinal fluid is accumulating and that's why it's creating a pressure, or there is a tumor, there is a bulge of a intervertebral disc that is causing a pressure on the spinal cord. To release the pressure, if you are doing any procedure through the skin, okay, to release the pressure on the spinal cord, if I am doing some procedure through the skin, then it is called as a percutaneous decompression of the neural elements, and the codes will be listed here. Whenever you code for spinal cord or vertebral column, always you have to remember for 4 things, like we discussed under musculoskeletal system. I told you to check for 4 things. First of all, check what is the procedure. Then check what is the approach of the doctor. Anterior approach, posterior, lateral, anterolateral, posterolateral, that is your check approach. The third thing you will check into which region of the spinal cord I am operating, cervical, thoracic, lumbar. And the last thing I'll check is how many vertebrae I'm dealing with. Based on that, I have to assign the code. Same guidelines you will apply here also when you code for spine. So for percutaneous decompression, same 4 things you have to keep checking. What is the procedure? It's decompression. But then into which part of the vertebral column, and cervical, thoracic, lumbar, what was the approach, and for how many vertebrae I did that procedure. Based on that, I assigned the codes. After this percutaneous decompression, there will be more decompression codes. This is just percutaneous. Sometimes you do it laparoscopically. Sometimes you cut open the patient to release the pressure on the spinal cord. So different codes will be there later on. This was only for percutaneous decompression. After that, you have got the codes for catheter implantation. Catheter implantation is, like we discussed earlier, injection procedure. When I'm injecting, I insert a needle, push the medication, done. I remove the needle. This is one-time procedure. But say my patient is chronically ill patient, sciatica patient, or say some other chronic illness is there and patient is into continuous pain. So instead of just injecting one time, what I'll prefer is I implant a catheter in some of the spinal spaces wherever required. Once that catheter is in place, you just attach a pump to it. That pump will be filled with a medication. So the patient will receive continuous medication through this catheter. When you attach that pump, in the pump you set the time and dose. So at the said time, the said dose of the medication will be released into the body. You don't have to inject every now and then to your patient then. So that catheter is placed. What I'm doing with the catheter, I have to check whether I'm inserting, removing. That you have to check, and based on that, you assign the codes for this catheter implantation. After that, you have got the codes for this pump implantation also. Like I said, for chronically ill patients, you just insert a pump also. The pump will be filled with a medication. Medication, you can choose which medication that is. And once that medication is there, you set the dose and time, then it will be released into the body. So you don't have to inject to your patients once that pump is in place. So for the pump also, you have to check what you are doing, whether you are inserting that pump, removing it, replacing it, refilling. Once the medication is like all used up, so you need to refill that medication into the pump. So for refilling the medication and everything, you will have different codes listed in here. So you have to check what is being done and assign the codes. The codes are simple. After this pump, the codes are there for endoscopic decompression of neural elements. I told you there will be more decompression codes. Earlier we saw percutaneous decompression. Now it is endoscopic decompression. Whenever there is pressure on the spinal cord and I am going to release the pressure by endoscopic approach, then I am going to use the codes listed in here. So here they have given all different definitions. What is called as percutaneous decompression, what is endoscopic decompression, what is open decompression. All these definitions are given to you. So you can read through these definitions later on. For endoscopic decompression, only one code is there. Then you have this other codes, that is for posterior extradural laminotomy or laminectomy procedure. This is also for decompression. These procedures also are performed for decompressing your spinal cord, but these will be open procedures now. When I'm going to cut open the patient, so where I cut it open from, back side, front side, lateral side, so anterior approach, posterior approach, and so on. Based on the approach, there will be different codes. Here are the codes for the posterior approach. When I cut open the patient from back side, which part of the vertebra will be exposed? Spinous process and laminas. So if I'm removing that, it is called as laminectomy. So laminectomy procedure, basically you will see under posterior approach. Laminectomy or laminotomy procedures to release the pressure on the spinal cord will be listed under posterior approach. So if you see starting from the code here, 63001, laminectomy procedure is listed. But if you go down and see from the code 63020, laminotomy procedure is listed. Whatever I do to release the pressure on the spinal cord, all the codes are there for the posterior approach. Be it laminotomy or laminectomy, carefully check your spellings, your suffix, and then you assign the codes. The guidelines will be same. You have to check which is the procedure, then check the approach of the doctor, then you have to check the region where the procedure is performed, and finally count the number of vertebrae on which the procedure is performed and assign your codes. After this posterior approach, you will have the next approach listed is transpedicular or costovertebral approach. Through the ribs, when you are going to reach out to the vertebrae through the ribs, that is basically posterolateral or anterolateral approach. You will have your codes listed here. in here, transpedicular or costovertebral approach procedure. In there, the codes are there. So whenever I am going to reach out through this vertebra, which part of the vertebra I will deal with? The lateral parts of the vertebra, that is your articular facets or transverse processes or the intervertebral disc. I will deal with to just operate on these parts of the vertebral column to release the pressure on the spinal cord. So all such procedures you will see in here. After costovertebral approach, you have this anterior approach. When I cut open the patient from front side, which part of the vertebra will be exposed? That is vertebral body. Vertebral body in medical terms, it is called as corposcopy, corpectomy, corpotomy. All these words, when you see, these are all from the anterior approach. You will see under anterior approach. So same guidelines you apply like for the vertebral column and you assign the codes. Then you have got lateral extracavitary approach. So based on the approach, you go to the respective areas, you match those 4 things which I asked you to, and you can choose your codes. All these codes are for decompression of the spinal cord. Whenever there is a pressure on the spinal cord and you want to release the pressure, you will perform these procedures, and these procedures are listed in here under spine, not under musculoskeletal system. Under musculoskeletal system, when the procedures are performed for different reason, not just to release the pressure on the spinal cord, but you are doing the procedures for some different reason, then the codes are under musculoskeletal system. Here only for decompression of the spinal cord, the codes are listed. Next, you have this excision procedure, incision and excision. All of you know what is incision and excision. When I cut open into the spine, I do something inside, close it back, the codes will be under incision. Excision is when I'm removing something, maybe a tumor, a polyp, a biopsy sample, or the part of the intervertebral disc or something related to the spine. If I'm removing, then the codes will be listed under excision. After excision, you have, for excision, again, you have to check the approach. When it's an excision procedure, approach, you have to check it, and based on the approach, the different codes are listed. So under excision, anterior or anterolateral approach, specifically the codes are listed in the next part. After excision, you have again stereotaxis and stereotactic radiosurgery. We just saw it for brain. Same guidelines applicable for spine also for stereotaxis and stereotactic radiosurgery. Next, you have neurostimulator. So as we discussed for the brain, neurostimulator, you have to check what they do with the neurostimulator. Insert it, remove it, replace some part of it, or they are going to repair it. What they are going to do, you have to check that. And where exactly that neurostimulator is inserted, the location you have to check. And based on that, you assign the codes. The guidelines are same like we saw for the brain. Same guidelines you apply here for neurostimulator, you code it. Again, repair procedure is there. So repair, directly when spinal cord or brain tissue is damaged, we cannot repair. But if the meninges over the brain and spinal cord are damaged, or the bones protecting these structures are damaged, then we can repair them. Only the repair codes deal with meninges or bones, not directly with the spinal cord. Next, you have this shunt or spinal CSF. It's same. So CSF procedure, that is cerebrospinal fluid shunt, we saw for brain. Same way it is for the spinal cord. So for spinal cord, again, you check where you have kept that shunt into cervical region, thoracic, lumbar. And then you have to check whether you insert that shunt, remove it, replace it, what you are doing with that. And based on that, you assign the codes. The guidelines are same like we saw for brain. That was the second part of the chapter for spine. Coming to the last part of the chapter, which is for the peripheral nerves. So all your peripheral nerves, those include the somatic as well as autonomic nerves. Somatic nerves further are classified into different types. Like you have sensory nerves, motor nerves, sympathetic, parasympathetic, and different types are there, which we just discussed into the video that was clearly mentioned. Whenever I'm going to code into the section for the nerves, I have to know the individual nerve which is being treated. Because for brain and spinal cord, you check the location. But the location is a wider portion of the brain or the part of the spinal cord which you are treating. But when I'm treating a nerve, I have to know which particular nerve I'm treating. Is it a facial nerve? It is a radial nerve? It is a sciatic nerve? Which nerve I am going to treat? That I have to exactly know. And that nerve comes under which category? Is it a somatic nerve, or is it a your autonomic nerve, or whether it is your paravertebral nerve? What type of nerve it is, I have to know. Then only I can go to the respective areas and assign the codes. If you don't know the type of the nerve, then you can check into each section, because it's difficult to find out the type of the nerve. If you're not from the medical background, then might be difficult for you. So what you can do is you can keep checking under every section. So say it's an injection procedure being done. So into which nerve I'm injecting? Say into the sciatic nerve. If I don't know, sciatic nerve falls under somatic category or autonomic category or paravertebral, I don't know. Then I keep checking into each section. Under injection, you will see there is one section for somatic nerves. Then if you go down, there will be another section that is for paravertebral nerves. And after paravertebral nerves, you will have another part for autonomic nerves. So in every part, you can keep checking if you don't know the type of nerve. But if you know, then you can go to that exact region and then you can start assigning the code based on the nerve. So the codes are same, guidelines are same. When it is injection, drainage or aspiration, you have to check the location and you have to check the whether it is diagnostic or a therapeutic injection. By location, you have to know the exact location of the injection or drainage, meaning which nerve exactly you are treating. Is it like a phrenic nerve, or it is a sciatic nerve, radial nerve? Which nerve I'm going to treat? Exactly name of that nerve you have to know. By matching that, you can choose your. So that was all about injection, drainage, aspiration. After that, you have got neurostimulator. Okay. So for neurostimulator also, you have to check when it's a neurostimulator, which nerve I'm going to stimulate. When it comes to brain or spinal cord, the part of the brain I stimulate. So wider part, actually, I'm stimulating like a cerebral region of the brain, or maybe the occipital part of the brain, or into the frontal part of the brain I'm stimulating. So that I know, it's like easy to understand. For spinal cord also, like whether into cervical region, thoracic, or into lumbar region I'm stimulating, I get to know. But when it is neurostimulator for a particular nerve, which nerve they are going to stimulate, that you have to know, and based on the name you have to match that exact name, right, left, because the nerves will be present on both the sides. So right, left, everything you need to match, and then you have to use the codes and also the modifiers. If it's right and left, like the nerve is present on both the sides, then use your modifiers RT, LT to specify that. Or if it is on both the sides, they are doing the procedure, use your modifier 50 also. For nervous system, always you have to make use of modifiers. All these codes are for unilateral procedures. Neurostimulator, again, you check what they do with the neurostimulator, insert it, remove it, replace it, repair it, what they do, and which nerve they are going to insert it for. Based on that, you have to assign the codes. Multiple codes for neurostimulator. After neurostimulator, you have the codes for destruction. Now, destruction procedure was not listed for brain or for spinal cord, because you cannot destroy a part of brain or part of spinal cord. Otherwise, your patient either will die or he will be paralyzed if you destroy a part of brain or spinal cord. So, destruction was not listed under brain and spinal cord. It is listed under peripheral nerves only. So, what is destruction? You destroy a nerve, a particular nerve, when it's causing a problem. I have tried all means of treatment. Maybe I just have tried, like say some nerve is causing a problem, it's painful condition for the patient. So I tried all different exercises, physiotherapies, medication, surgery, everything I have tried. But with that also there is no relief. Then what I do, whichever portion of the nerve is causing a problem, I destroy that part. How do I destroy it? For destruction, I can use various means. I can either apply radiation, I can apply some neurolytic agents, I can use a cautery, I can just do some like apply some chemicals, chemodenervation I can do. So all various means I can use to destroy a portion of the nerve. Usually when your nerves are like they are degenerated and causing problems or something like that, then you better go for this procedures. When no treatment is giving you relief, then you go for such procedures. So that is what is destruction. Under destruction, again, you will check which nerve you are destroying and how you are destroying. How meaning by using a chemical or neurolytic agent, by cautery, or by applying a radiation, how you are destroying. Based on that, all different codes will be there. So you just have to match those things and use your codes. After destruction, you have the next procedure, neuroplasty. Neuroplasty is again repair. So repair procedure we saw on the brain and spinal cord also, same way it is neuroplasty, or there will be another procedure called neuroraphy. Both are repair procedures for the nerve. When you do neuroplasty, neuroplasty is basically when the nerve is being compressed. There is pressure on the nerve or the nerve is degenerated. To repair that nerve, if I am doing some procedure, then I do neuroplasty. But say nerve was in like healthy nerve, but in an accident it's broken. In an accident, the nerve is broken into two parts. So I need to reconnect those two parts so that it will function again. So when I'm doing that, it's called as neuroraphy, suturing back the portions of the healthy nerve back together, neuroraphy. When the nerve is diseased or degenerated or there is a pressure and I am trying to release that, then it's called as neuroplast. Both are repair, but different techniques and different reasons to repair. So neuroplastic codes are here. Again, you will check which nerve you are repairing, and based on the nerve, you assign the codes. Then you have the codes for transection or avulsion. Avulsion is basically when the nerve is being crushed, completely crushed. Then to treat that nerve, whatever procedures are done, those will be listed here. So check which nerve is being treated for avulsion, and then you can assign the codes. So simply all the codes basically under peripheral nerves are depending on location. Which nerve you are treating, based on that you are coding it. Then excision of a nerve and lastly, neuroraphy procedure. Like already I explained neuroraphy, suturing of the nerve together. So that was all into this chapter, nervous system. Thereafter, you don't have this neuroraphy with a nerve graft and everything. That is same thing. So all these codes are there and those all will depend on the location. Any doubts? We are done with this chapter, nervous system. Okay.
Okay, ma'am.
What I'll do is I'll put up few questions. You can solve few questions and then we will move to the next part. Okay. Do this 4 questions. Okay. Do this 4 questions. We will discuss the answers and then we will have a short break. Back. Done. Always first check whether the procedure is done on brain, spinal cord, or nerves. Go to that part, then check what is the procedure. Is it neurostimulator or CSF, shunt, or is it incision, excision, or injection? Go to that respective code range and then you can start searching for your codes. Neetu, you can check your first question. You're close, but that is not the correct code for first question. First question will need two codes. Okay, Rimsha, you have got it right. Second, I think is correct for Neetu. First question needs two codes. If you're not getting two, at least you should get one. Carefully check.
Okay, ma'am.
Done. Everyone is getting a different code. We'll check it together, okay? Gitanjali, you have got first question. Correct, code is correct, but one more code is needed. Other questions I'm not sure about. We will check it together. All other questions, okay? I'll give you another 2 minutes and then we will discuss the answer. Yeah. I share answers. Done.
Last question.
Last question.
Third.
Okay. Third. Removal of implanted. This one. Huh? This is spinal neurostimulate.
No, second one.
Second one. Injection. Okay, so go to spine, under spine, go for injection, drainage, and aspiration procedure. Very first procedure listed under spine. Then check, match this description: cervical, epidural. Phenol is a analgesic medication. Okay, so you can use this course. Name of the medication is written because to understand whether it is anesthetic or analgesic. Okay. Fourth question, you got it? This is related to what?
This
Craniotomy.
Yeah.
So craniotomy procedure, go check, match this description.
This.
Yeah, hematoma is collection of blood. So you are going to remove this, release hematoma, evacuate that hematoma, and match the location, match the reason, and you can choose the code. Okay, I'll share the answers. Check it. You can do it later on. Okay. Here, first question. Using an operating microscope, physician performs a neuroplasty of right ring finger, and you have to code it. So, what is the procedure done? Neuroplasty. Neuroplasty is the procedure performed for peripheral nerves. Okay, not for brain, not for spinal cord, but it is done for the peripheral nerves. So I'll go to the section peripheral nerves. And the peripheral nerves, you will specifically find neuroplasty procedure. When you go to neuroplasty, you have to check which part of the body they do it for. Right ring finger. Finger is your digit. Okay, so it's called as neuroplasty digital. So you are doing it for your digits. That's why it's called as digital. So digital neuroplasty, that will be the code you will find. You have to assign that code. Along with the code, you have to use modifier F8. F8 is specifically for ring finger. There is a specific modifier available. Not just RT, LT you use, but for the right ring finger, a specific modifier is available. You use that modifier. So your code is 64702 and modifier F8. Along with that, for doing this procedure, what the doctor is doing, he is using the operating microscope. So if you have found this code 64702, then just above the code, you will see a note is there. For all the codes related to neuroplasty, they have written a common note there that if the procedure is done by using an operating microscope, then you have to use an additional code for the use of operating microscope. And if you read that note, then you'll get your second code. In the note, this code is written 64727 to be additionally used for the operating microscope. And that will be your second code. This is an add-on code basically. So that's how you have two codes for the first question 64702 with modifier F8 and 64727. Coming to second question, cervical epidural spinal injection of phenol. So what is done? Which procedure? Injection. Where? Spine. So I'll go to the spine section. Under spine, I go to injection, drainage, aspiration procedure. Then I match this description, that is the location is cervical and epidural, and what they are injecting, phenol. So it's a analgesic, so I can choose the codes which are listed in this chapter. No need to go to anesthesia chapter. So match the location, cervical, epidural, and you will get the code 62281. Most of you have got it right. Coming to question number 3, removal of implanted spinal neurostimulator pulse generator. What they are doing? Removing what? The neurostimulator pulse generator, meaning the batteries of the neurostimulator they are removing. Where this neurostimulator is inserted? Spine. So I go to spine. Under spine, I go to neurostimulator. Under neurostimulator, I have to check the removal codes, and that too just removal of the batteries, removal of the pulse generator I have to choose for. not the removal of entire neurostimulator. Only the batteries are being removed. So match that, you will get this code 63688. Last question, craniotomy for evacuation of subdural hematoma supratentorial. Now here, what is the procedure done? Craniotomy, cranium, skull bones. So go to first part of the chapter, brain. Under brain, there is specifically craniotomy and craniectomy section is there. Go in there. Then match the location and match the reason. You will get your code. So the correct code will be 61312. Okay. Any doubts? Yeah.
So in the first question, you have to also include the 64704 or no need.
64704, what is it?
It's just a nerve of hand.
No, hand and fingers different. Hand will be from here. Okay. No need for two codes. Okay. When you're coding, it's just for the digits. Done. Hand is this part. Palm, basically, from wrist joint onwards. 64704, you said, right? No, no. You'll not use this code. Only this, digits.
Excuse me, ma'am. Where these codes are mentioned, like F8, F8 is specifically for the ring finger, and
Yes, that is appendix A. Last page of appendix A, you can check where all HICPIC modifiers are listed. Okay, F1, F2, like all these modifiers are there. E1, E2 for eyelids, for digits, for toes. All the specific modifiers are there. Those are listed in appendix A. Last page of appendix A, you will find them. Any other doubts? No? Then you can take your break. Will you come by 1 o'clock? 12:38, right? 20 minutes break enough, right? Come back by 1 o'clock and we will start again.
Okay.
Okay, ma'am.
Across the whole planet, humans eat on average between 1 and 2.7 kilograms of food a day. That's over 365 kilograms a year per person, and more than 28,800 kilograms over the course of a lifetime. And every last scrap makes its way through the digestive system. Comprised of 10 organs covering 9 meters and containing over 20 specialized cell types, this is one of the most diverse and complicated systems in the human body. Its parts continuously work in unison to fulfill a singular task, transforming the raw materials of your food into the nutrients and energy that keep you alive. Spanning the entire length of your torso, the digestive system has 4 main components. First, there's the gastrointestinal tract, a twisting channel that transports your food and has an internal surface area of between 30 and 40 square meters, enough to cover half a badminton court. Second, there's the pancreas, gallbladder, and liver, a trio of organs that break down food using an array of special juices. Third, the body's enzymes, hormones, nerves, and blood all work together to break down food, modulate the digestive process, and deliver its final products. Finally, there's the mesentery, a large stretch of tissue that supports and positions all your digestive organs in the abdomen, enabling them to do their jobs. The digestive process begins before food even hits your tongue. Anticipating a tasty morsel, glands in your mouth start to pump out saliva. We produce about 1.5 liters of this liquid each day. Once inside your mouth, chewing combines with the sloshing saliva to turn food into a moist lump called the bolus. Enzymes present in the saliva break down any starch. Then your food finds itself at the rim of a 25 centimeter long tube called the esophagus, down which it must plunge to reach the stomach. Nerves in the surrounding esophageal tissue sense the bolus's presence and trigger peristalsis, a series of defined muscular contractions. That propels the food into the stomach, where it's left at the mercy of the muscular stomach walls, which pound the bolus, breaking it into chunks. Hormones secreted by cells in the lining trigger the release of acids and enzyme-rich juices from the stomach wall that start to dissolve the food and break down its proteins. These hormones also alert the pancreas, liver, and gallbladder to produce digestive juices and transfer bile, a yellowish-green liquid that digests fat, in preparation for the next stage. After 3 hours inside the stomach, the once shapely bolus is now a frothy liquid called chyme, and it's ready to move into the small intestine. The liver sends bile to the gallbladder, which secretes it into the first portion of the small intestine, called the duodenum. Here, it dissolves the fats floating in the slurry of chyme so they can be easily digested by the pancreatic and intestinal juices that have leached onto the scene. These enzyme-rich juices break the fat molecules down into fatty acids and glycerol for easier absorption into the body. The enzymes also carry out the final deconstruction of proteins into amino acids and carbohydrates into glucose. This happens in the small intestine's lower regions, the jejunum and ileum, which are coated in millions of tiny projections called villi. These create a huge surface area to maximize molecule absorption and transference into the bloodstream. The blood takes them on the final leg of their journey to feed the body's organs and tissues. But it's not over quite yet. Leftover fiber, water, and dead cells sloughed off during digestion make it into the large intestine, also known as the colon. The body drains out most of the remaining fluid through the intestinal wall. What's left is a soft mass called stool. The colon squeezes this byproduct into a pouch called the rectum, where nerves sense it expanding and tell the body when it's time to expel the waste. The byproducts of digestion exit through the anus, and the food's long journey, typically lasting between 30 and 40 hours, is finally complete.
Okay, so that was all about digestive system. It starts from your mouth and ends into the anus, in between all the different organs, so which form your digestive tract, and the digestive glands are separately listed. Okay, so digestive glands include your salivary glands, liver, gallbladder, pancreas. These all together will form your digestive glands. And digestive tract is from mouth, then esophagus, stomach, small intestine, large intestine, rectum, anus. That is your digestive tract. When you will see the code arrangement into digestive system, the codes are arranged as per body parts from top to bottom in the descending order. Every body part will be listed, and the possible procedures on that body part will be listed in the respective section. First, you will have codes for digestive tract. And then in the end, after the anal region, you will have the codes for digestive glands. For liver, gallbladder, and pancreas, the codes will be listed towards the end. Once you have all the codes for digestive tract and glands, then you will have codes for the protective membrane for all these organs, that is your abdominal wall. So in the end, the codes for the abdominal wall will be listed. So that is how the code arrangement will be. When you are going to code into this particular chapter, every organ, under every organ, you are going to see the usual procedures like incision, excision, repair, reconstruction, laparoscopy, endoscopy, or introduction, and so on. So like we saw with the other chapter, same way for this chapter also, for every organ, the similar procedures will be listed. Only there is a difference when you are coding for endoscopy. If you are coding for endoscopic procedures on any organ, the codes are listed into the respective areas if the endoscope is performed through natural opening of the body. What are the natural openings to reach out to the digestive organs? One is through mouth, the other is through nose, The third is through anal region. So from any of these openings, if you enter the endoscope and do the endoscopy, the codes are listed into the respective organ section. Like if it's endoscopy for esophagus, I'll find the endoscopy codes under esophagus. If it's endoscopy for small intestine, I'll find the codes under small intestine when it is done through natural opening of the body. But there is another way to do the endoscopy, if not through all these openings. Like say when I want to do the endoscopy of small intestine. Small intestine, it's a very long distance if I push the scope from nose or mouth. Then I have to go down into the esophagus, then stomach, then the small intestine, first part, then second part, third part, like that. It's a long distance for the doctor to push that scope. Or if I do it from the anal region also, it's a long distance. Like from the anal region, then you push it into the sigmoid colon, this descending colon, transverse colon, ascending colon, and then into the small intestine. Again, a long way. So doctors, what they prefer is to create an opening. They will create a surgical opening somewhere onto the organ from the abdomen, and from there they will directly push the scope into the intestines. Usually for intestines, they prefer this route because it's the shorter route to reach out there. So if they are doing any endoscopy through the surgical opening, then your codes, be it for if they are doing it for esophagus, stomach, small intestine, large intestine, doesn't matter. All the codes for endoscopy, when it is done through surgical opening, the codes are listed under small intestine section. Okay, so anytime if you want to code endoscopy through stoma, ostrom is the suffix, you understand, right? Ostomy is when the doctor creates a permanent surgical opening, then you use the suffix ostomy. Same way, it's stoma. Stoma means surgical opening. Through the surgical opening, I'm doing the endoscopy. The codes are listed under small intestine. Another variation is for the endoscopy of stomach and first part of small intestine, that is duodenum. If at all I'm doing the endoscopy for stomach and duodenum, the codes are not listed into the respective organ sections. The codes are listed under esophagus. Why? No reason, but all your codes for endoscopy for stomach and duodenum will be listed under esophagus, not into the respective organ sections. That is the only two things, if you remember. The coding is going to be easy into this chapter because not much guidelines listed in here. Remember only this difference about the endoscopy. All your codes are arranged as per body parts from top to bottom in the respective order, descending order, and then you just will see all different procedures listed into the respective organ sections, except for endoscope, stomach, and duodenum, which is listed under esophagus. And whenever it is endoscopy through surgical opening for any organ, it will be listed under small intestine. So all your codes for digestive tract will be in first place, then for digestive glands, and last for the protective membrane, that is abdominal wall. Now we'll check the codes. I'll just emphasize on few codes which are important and wherever the guidelines are. Otherwise, the codes are very simple and direct. So the first organ listed under digestive system, lips. So any procedure performed on lips, be it many times it's a cosmetic procedure. Nowadays, very commonly, this female patients, they would like to change the shape of the lips and lip fillers and everything. So all this procedure codes you'll find in here. But remember, if the procedure is done for cosmetic reason, insurance companies will not approve it because it's not required medically. Okay, so always you need to have a medical necessity to perform the procedure, only then it will be approved. Otherwise, the codes are here. Whatever you want to code, be it for cosmetic reason or for medical reason. Like in a medical condition, patient had an accident, damage to the lips, now you're repairing it, the codes are there. So all these codes are there. This direct codes, no need, no specific guidelines also. You just have to read the description, what is the procedure they do, whether it's excision, incision, or whatever. The codes will be listed into the respective areas without any specific guidelines. After lips, you have the next organ listed is vestibule of mouth, nothing but your gums. So whenever they are going to perform these procedures on the vestibule of mouth, again, same way, there are no specific guidelines. It is incision, excision, dissection, all these procedures. If you are working with a dentist, Most of the times you'll come across these procedures because we are just started with the mouth. Inside mouth, you are going to have various different structures like your teeth, tongue, vestibule, then palate, uvula. All these structures are a part of your mouth. So in the beginning, all these structures are listed and the procedures on them. So if at all you're working with a dentist, then you can make use of these codes. But apart from these codes, dentists will use further more codes, and for that there is a separate course. Okay, dental coding is a separate course, and there will be much more codes listed apart from the CPT codes. These codes also you can use it, but for dentistry, few more codes will be there. Next, you have this tongue and floor of mouth. So, if at all the doctor is performing any procedure on tongue or floor of mouth, you have to check the approach of the doctor. For tongue, there will be two possible approaches: internal, that is intraoral approach, or extraoral approach. You ask your patient to wide open the mouth and operate on the tongue. If the patient say temporomandibular joint is fractured, he cannot open the mouth, then I can do the procedure from outside also. I can take an incision over the patient's cheek and I can reach out to the tongue and I can operate. So various ways are there. You have to check the approach, whether it was intraoral or extraoral, and based on that, you assign the codes. Like if you see for tongue and floor of mouth, incision procedure, very first code 41000. It says intraoral incision and drainage of abscess, cyst, or hematoma of tongue or floor of mouth. So this is what is the drainage procedure they are doing, but the approach uses intraoral. But if you see the next code, not next, 41015. 41015, same procedure, drainage. But this approach used is extraoral approach. So always check what approach the doctor is using. Based on that, you assign the codes. The procedure might be same. The other codes related to tongue and floor of mouth will be direct. So excision, repair, other procedure codes are there. After that, you have next is dentoalveolar structures. So for dentoalveolar structures, very few codes. Again, same procedures are listed: incision, excision, destruction, repair, and so on. So that is all direct codes, no specific guidelines. Next, you have is a palate and uvula. Now, when you're coding for palate and uvula, the commonly performed procedure on palate is palatoplasty. When I say palatoplasty, what kind of procedure it will be? Incision, excision, repair, destruction. What kind of procedure will it be? Where should I find my codes? Palatoplasty.
Repair.
Yeah, oplast is the suffix. When you know the suffix oplasty, it has to come to your mind. It's repair, not incision, not excision. If it's excision, ectomy should be the suffix. If it's incision, otomy should be the suffix. So by knowing the name of the procedure, you can make out. So better you go through those lists, whatever I showed you in the previous class, that your prefix, suffix, and root lists are there. So you read through this list every time, so you can be get familiar with all these terms. Okay. So palatoplasty, I was saying, other procedures do not have any specific guidelines. Incision, excision, these are direct codes for palate and uvula. But when it comes down to coding palatoplasty, doing palatoplasty one time will not be usually sufficient. Palatoplasty either can happen as a congenital condition. By birth, the patient is born with a cleft palate or some defect into the palate. Palate is nothing but roof of your mouth. So it separates your nasal cavity from your oral cavity. Now, if there is a opening between the palate, like cleft is there, so directly nose and mouth are connected, patient will not be able to breathe, he will not be able to eat. Immediately, you have to do the surgery after birth. When you do that surgery, you close that. Later on, the baby is going to grow. With the growing child, with the growing bones, again, the opening will be created because the size is increasing, and that's why the opening happens again. So you need to revise that procedure again. Again, you have to close it back. So you keep on repeating till the child is growing. When you do it for the first time, it's called as palatoplasty as your primary procedure. But when you do it again, second time, third time, that is called as a secondary procedure. Okay. secondary lengthening or secondary procedure. That is what is the word you will use, or revision procedure basically. This is what is the words primary and secondary mean. When you do the procedure for the first time, primary procedure. When you do it second, third time, it's a secondary procedure. But the meaning of these words can change also. So when I am doing multiple procedures together, the focus of the treatment, whatever that surgery is, that I call it as primary procedure. And along with that surgery, other surgeries which are done, I call them as secondary procedures. So you can interpret these words in both the ways, primary and secondary. When I am going to code for palatoplasty, as I said, it can happen as a congenital condition, cleft palate, or sometimes when the patient is adult in an accidental injury, the palate is damaged, I need to repair it. So again, I have to do a palatoplasty. So it can be acquired condition also. So if at all it is an acquired condition, my code will be different. And if I am just doing palatoplasty for a congenital condition, my code will be different. So if you see here under repair, the first code 42180, it is for repair of laceration of the palate. Laceration usually will not be by birth. It is an injury which will happen after birth only. So this particular code will be used when it's an acquired condition. When you are repairing the palate for any acquired condition, then you use this codes 42180 or 82. The next code 42200, if you see, it is palatoplasty for cleft palate. Cleft palate is by birth only. So whenever I am going to treat this cleft palate, when it's a primary procedure, I use this code starting from 42200 till 42210, whatever codes are there, these are for the primary procedure when palatoplasty is done for the first time. But when I am going to repeat it, for that I do have the next code starting from 42215 onwards. All these codes are for secondary revision of the palatoplasty. So this is all, there's different codes. So when you code for palatoplasty, check whether it's primary or secondary, whether it is done for acquired condition or congenital condition, and based on that you assign your codes. After this, you have the next organ listed is salivary gland and ducts. So these are digestive glands located at the base of the mouth. Any procedure performed on salivary gland, the codes will be listed. The codes are simple, no specific guidelines, incision procedure, excision, other procedures. So all these are direct codes. Next, you have pharynx, adenoids, and tonsils. These are also located at the base of the mouth. So your mouth opens into a tube called pharynx. Pharynx is a small portion which is a common duct for your respiratory organs as well as for your digestive organs. We discussed that when I respiratory system is covered. We did it together, right? So in the respiratory system, when I discussed, I told you pharynx is a common passage for the digestive tract as well as for the respiratory tract. In here, you will have epiglottis located. That is a one-way valve which will keep your respiratory tract all the time open and digestive tract closed. Only when you're pushing your bolus of food inside, at that time, this epiglottis will close the respiratory tract and open the digestive tract. So that is what is at the base of the pharynx, you will find this epiglottis. Pharynx related all codes are listed here. You will not find them into respiratory system. Though it's a common passage for both, but the codes are listed here. Now, pharynx, adenoids, and tonsils. Adenoids and tonsils are a part of your immunity system, that is your lymphatic system. But as these are the organs located by the side of your pharynx, the codes are listed here. This here you will find few combination codes for adenoids and tonsils. There are few combination codes listed. So here, if you see incision procedure, direct codes. Excision, that is excision of adenoids. When it is done, it is called as adenoidectomy. Excision of tonsils, if it is done, then I call it as tonsillectomy. So if I'm going to remove tonsils alone, I will code it as a separate procedure, tonsillectomy. If the doctor is going to remove only adenoids, I will code it as separate procedure, adenoidectomy. But when doctor is going to remove both together, adenoids as well as tonsils are removed in the same operative session, do not code it separately. You have a combination code available. So if you go down, you will see this code 42820. This code is for tonsillectomy and adenoidectomy. When both the procedures are done together, I will not code them separately. I will use this combination code, and these codes depend on the age of the patient. Okay, so what is the age of the patient? Based on the age of the patient, you assign either 42820 or 821. The next two codes, if you see 42825 and 826, these are for tonsillectomy alone. If the doctor is going to perform tonsillectomy alone, then again check what is the age of the patient and assign the code, one of the codes. The next four codes, 42830 till 836, these all codes are for adenoidectomy procedure. When doctor is going to remove only adenoids, then check whether it was performed as a primary procedure or secondary procedure. I already explained what is primary and secondary. So when it's done as a primary procedure, either 830 or 831, depending on the age of the patient. And when it is done as a secondary procedure, either 835 or 836, depending on the age of the patient, you have to choose. When the procedures are done together, do not code them separately, though separate codes are available. If I say a doctor is removing adenoids and tonsils in the same operative session, and I code with 825 and 830, then it's wrong coding. It will be considered as a fraudulent act, and there will be heavy punishments for that. So whenever combination code is available, you are going to go and use a combination code. So here it is combination code 820 or 821. Next, you have other procedures, repair procedures for pharynx, adenoids, tonsils. These direct codes are there, no specific guidelines. Coming to the next procedure, esophagus. So far we were discussing all the structures located inside the mouth, starting from lips, vestibule, then your tongue, then palate, uvula, and everything. So all the structures located inside the mouth. Now we are moving to the next part of the digestive tract, esophagus. Esophagus is a long tube extending from the base of the mouth till your stomach. It is going to pass through your neck region, chest, and then going to reach out to the abdomen. When the doctor is going to operate on esophagus, he might not operate on entire length of esophagus. He will be operating on a smaller portion of the esophagus. So you have to always check what is the approach of the doctor when the doctor is performing procedure on esophagus. Whether he is making the opening into the cervical region or into the thoracic region or into the abdominal region, and based on that you choose the code. Maybe the procedure is same, like here if you see on the esophagus incision, 43020 is the code, that is esophagotomy cervical approach. Okay, so doctor is performing esophagotomy, but he is making an opening into the cervical region, that is into the neck region. If you see the code 43045, same procedure, esophagotomy, but here it's a thoracic approach. So when you are making an opening into the chest region, you will use this code. So though the procedure is same, depending on the approach, you have to change your code. Same way for excision also, you will see 43100. It is for excision of lesion, esophagus with primary repair, cervical approach. If the same procedure is done by either thoracic or abdominal approach, your code will be 43101. So depending on the approach, you keep changing your code for esophagus. Everywhere, whatever is the procedure for esophagus, everywhere you will keep on checking the approach of the doctor, and based on the approach of the doctor, you are going to assign the codes. After that, you have got endoscopy codes for esophagus. Endoscopy of esophagus is called as esophagoscopy. Earlier also I mentioned the guidelines of endoscopy to you. Whenever endoscopy is performed, always you have to check whether it is done for diagnostic reason or therapeutic. Different codes will be there. If a diagnostic procedure turns into therapeutic, you have to code it as a therapeutic procedure. Then we discuss endoscopic procedures are closed procedure, but if any endoscopic procedure turns out into an open procedure, then you'll code it as an open procedure. And lastly, I told you if bleeding occurs as a result of any endoscopic procedure, then you then you will not code for control of bleeding separately. It's a job of the doctor to control that bleeding. Same guideline is written here if you read. Page number 344, endoscopy. When bleeding occurs as a result of endoscopic procedure, control of bleeding is not reported separately during the same operative session. When you go down, there are codes for esophagoscopy. For esophagoscopy, when you code it, to reach out to the esophagus, I do have two ways to go down there. Either I can push my scope through mouth or through nose. If I am pushing the scope through mouth, it is called as transoral esophagoscopy. If I am pushing the scope through nose, then it is called as transnasal esophagoscopy. So you'll check that whether it's transoral or transnasal. Check whether it is diagnostic or therapeutic. Then check what type of scope they have used. I have discussed the types of scopes also under respiratory system. Either it can be rigid scope or a flexible scope. So if they use a rigid scope or flexible scope to do that endoscopy, you have to check that, match all these things, and then you choose your codes. So all these different codes will be there. There's all things, whatever I mentioned, you match and you choose your codes. After that, you just have, after esophagoscopy, as I told you, when it comes down to endoscopy, the codes for the endoscopy of stomach and duodenum are listed under esophagus. So after esophagoscopy, you have esophagogastroduodenoscopy. When the doctor performs the endoscopy for esophagus, stomach, and duodenum together, you do have codes listed in here under this section, esophagogastroduodenoscopy. In short, it is called as EGD. If they ask you to code for EGD, you will come down here and you will code it from here. So multiple codes are there for esophagoscopy, EGD, and the codes will start from 43235 onwards. All these codes are there for esophagogastroduodenoscopy, flexible, transoral, and so on. So always check transoral, transnasal, diagnostic, therapeutic, rigid scope, flexible scope, and further any details are required, match that and you have to code it. After esophagogastroduodenoscopy, you have the next procedure, endoscopic retrograde cholangiopancreaticography. We are checking the organ esophagus. Under esophagus, we are checking endoscopy codes. So under endoscopy, we saw esophagoscopy, then we saw EGD. Now this is the third procedure, ERCP. Endoscopic retrograde cholangiopancreaticography. When the doctor is going to do the endoscopy for the ducts of liver, gallbladder, and pancreas. These ducts, they open into the duodenum, first part of your small intestine, where these ducts will open. So if you are doing the endoscopy for these ducts, then the codes will be listed here, not into the respective organs. Under liver, gallbladder, pancreas, you will not find these codes for endoscopy. Okay, endoscopy codes, that is ERCP codes, are all listed here under esophagus. Again, the codes will start from 43260 onwards. All these codes are for ERCP. Always match the description for endoscopies, because along with the endoscopy, sometimes you do biopsy, sometimes you do cell washing, brushing, or maybe some other cautery and everything. So you have to check what else is done with endoscopy, match that description with your code description, and then you choose your codes. And you know about your modifiers. 52 and 53. Yeah. Modifier 52 and 53. What is it? 52
For
is reduced
service. Reduced service.
Sorry, it's reduced service. 53 is discontinued procedure. And when to use it, you know that. When the doctor is not doing the endoscopy entirely for whatever organ it is supposed to be, the doctor should visualize the entire organ. If the doctor is not visualizing, he is going to stop in between, use 52 when the doctor stops willingly. If the doctor stops because of some medical condition, because of some life-threatening scenario to your patient, then use 53 for all endoscopies, okay? Then you have laparoscopy procedure for esophagus. Again, when you code any procedure into esophagus, you have to check the approach of the doctor, cervical, thoracic, or abdominal, and then you code it. The codes will be direct codes. After that, repair codes for esophagus. So esophagoplasty and all these procedures will be listed in here. So the codes are direct, no specific guidelines. So I'm moving on little fast. Okay. Then you have manipulation codes. Manipulation, you understand manipulation when the doctor is going to manually manhandle the organ. Then it's called as manipulation. Usually when there is esophageal stricture or some like this, it's some obstruction to the esophagus, something is stuck or something like that, then you are just going to dilate the esophagus, that is manhandling you are doing, and that is all these codes you will be listed here, dilatation of esophagus and so on. Next you have the next organ listed is stomach. For stomach also all codes will be direct codes, but when it comes down to coding, have you heard of bariatric surgery? Bariatric surgery is the surgery performed for the patients who are obese. Obese patients, when they are not able to reduce their weight, you have tried all means of diet, exercise, or maybe some medications and everything to lose the weight, but still the weight is constant or it's still increasing and causing health problems into the patients. Then you consider this surgery called the bariatric surgery, or you call it as gastric restrictive procedure. The medical term is gastric restrictive procedure, where you reduce the size of the stomach. When you need to reduce the size of the stomach, what you do is you cut short the stomach, either horizontally or vertically. You remove some portion of the stomach. That is one way to do it. Or the next way is I completely bypass the stomach, remove the stomach from the from its way. Instead, I create small there, and then that will be connected to your rest of the intestine. So that is called as gastric bypass. So gastric restrictive procedure by gastric bypass. You bypass the stomach from its way. The third way to do it is, instead of cutting short the stomach, either vertically, horizontally, or bypassing it, you apply gastric bands. Like I told you, for aneurysm, you have some elastic bands. Similar way, you will have elastic bands, or it's a device, constriction device, which you apply over the stomach, which will not let the stomach expand. So that is what is specifically, when this is the way to reduce the size of the stomach by using these bands over the stomach, then you call it as bariatric surgery. If you are using the other ways like horizontal or vertical sectioning of the stomach to reduce the size or to bypass the stomach, then you call it as gastric restrictive procedure. So all three ways are there. Either you can do all these procedures laparoscopically, or you can do these procedures as open procedures. Usually when your patients are obese and they cannot reduce the weight by any means, and that is causing health problems, then only this surgery is indicated. Now, for performing the surgery, how the surgery is done, based on that, there will be multiple codes for this procedure, gastric restrictive procedure. And the codes are classified into three sections. There will be one section, laparoscopy. So whenever this procedure is done laparoscopically, you will have all codes listed under laparoscopy. Then there will be another section called bariatric surgery. So when this procedure is done laparoscopically, but the way to reduce the size of the stomach is by application of the bands over the stomach, then it is bariatric surgery. Under that, you will find the codes. The third section will be other procedure section, where you will find more codes for this gastric restrictive procedure. When it is done as an open procedure, all the codes will be listed under other procedure section. Otherwise, there are no guidelines into stomach. So incision codes, very direct. Excision codes are there. So whenever you are removing something from the stomach, the codes are under excision. Then comes the laparoscopy part. So here you find all your codes for gastric restrictive procedure, 43644 onwards. All codes are for gastric restrictive procedure when it is done laparoscopically. Then you have codes for introduction when you insert anything into the stomach. any medical device, so usually into the stomach, what you insert is a nasogastric or orogastric tubes. The patients who are not able to eat by mouth, you directly push the tubes into their stomach, and through the tubes, you will feed your patients. So that is what is insertion of these tubes you will find under this introduction. Then you have the codes for bariatric surgery, as I mentioned. So that is again a gastric restrictive procedure, but the way to treat is by application of the gastric bands or a restrictive device on the stomach. Then you have codes listed under bariatric surgery. These are also laparoscopic procedure codes. But if these same procedures are done as open procedures, then you have codes listed under other procedure section. Can you see? Here this code 43846, gastric restrictive procedure. So multiple codes are there for gastric restrictive procedure and the other procedure section also. But whatever these codes are, these are for open procedure. So always check when the doctor is going to operate on stomach, specifically this gastric restrictive procedure. Check whether it is done laparoscopically or open procedure. If it's laparoscopy, then what is the way how they treat it? By sectioning the stomach or by application of the gastric bands. So if it's sectioning the stomach, then you have the codes listed under laparoscopy. But if it's by use of gastric bands, then the codes are listed under bariatric surgery. And for open procedure, you have codes listed under other procedure section. That was all about stomach. Coming to the next organ, that is intestine. So intestine, when they use the word intestine, they are referring to small intestine. Okay. When they want to refer to the large intestine, they will use the word colon. Okay. So small intestine is divided into three parts: duodenum, jejunum, and ileum. Whenever I am going to code for intestine, always I have to check for which part of the intestine the procedure is done. Because you will not operate on entire length of intestine all the time. It's a very long organ. So you will operate only on a small portion of the intestine whenever it's a requirement. So you have to check which part of the intestine the doctor is operating, whether it's duodenum or jejunum, ileum, which part, and based on that the codes will change. All these codes, incision codes, very direct codes, you just have to match the description coded. Coming to excision. So excision includes your codes for transplant, intestinal transplant. If required, then the codes are listed under excision. We have already discussed this transplant procedure. Whenever transplant is performed, it is done into 3 steps. First, you do the procedure on the donor, then the backbench work, and finally the procedure on the recipient. For each step, you have to assign a separate code. And all these codes, like other organs, same way these codes for intestines also are there. After intestinal transplant codes, you have got codes for laparoscopy. Any laparoscopic procedure performed on intestine, the codes will be listed under laparoscopy. Under laparoscopy, again, they have listed incision, excision, and so on. But this incision, excision is not an open procedure. Earlier, incision, excision, what was listed is an open procedure. If at all it is done laparoscopically, you have to come down to this part and code it from here. Then under this laparoscopy, you have one more procedure called enterostomy. What is enterostomy? Ostomy is the suffix. So you know it's a permanent surgical opening created into the intestines is called as enterostomy. Many times your patients need it when, say, it's a cancer. So you removed a portion of the small intestine and there is no sufficient intestine left to join the proximal part and the distal part to join it back. You don't have sufficient length of intestine maybe. Or the cancer was metastatic and you are expecting it will regrow. So you'll not connect it back. You'll keep it like that. So what you do is whatever portion of the intestine you remove from there, you insert a tube and that tube is connected outside to a bag. So whatever your fecal matter, it will come out through that so whatever opening you have created into the bag. It will not pass out through the anal region. So when you keep that opening permanently there, then you call it as enterostomy. Or it's called as fistula. Fistula is an abnormal opening. Anywhere, whenever there is an abnormal opening, then you call it as a fistula. So you are creating that abnormal opening into the intestine. So it's called as a external fistulization. So here enterostomy codes are there, and then excision. These are all listed under laparoscopy when you do the procedures laparoscopically. And then again, enterostomy is listed here in the bold words. If you see, this font size is different. So this is for the open procedure. Enterostomy listed at the end of the page. This is for the open procedure when you do that creation of the surgical opening you do as an open procedure. When you do it laparoscopically, the first heading on the page, if you see, it is enterostomy when it's done laparoscopically. When it's done as open procedure, this last portion you can see enterostomy, and from there you code it. After that, you have got endoscopy codes for small intestine. So when it's endoscopy of duodenum, called as duodenoscopy. When you do endoscopy of ileum, it's called as ileoscopy. And when it's endoscopy for jejunum, you call it as jejunoscopy. If you do the endoscopy of entire intestine, small intestine, then you are going to call it as the small intestinal endoscopy. For small intestinal endoscopy, if the doctor is going to visualize entire intestine, the codes will be different. If the doctor, like I told you, small intestine is a very long tube. So maybe I'll not check the entire tube, because the problem, when I diagnose the problem, I'll stop there. So if at all the doctor is not checking the entire length of the intestine, only the first part, that is duodenum and jejunum, and he's not checking ileum, then I should not code for it. There will be different codes available. No need to use modifier 52, 53, because you will have separate codes for the length of the intestine check till jejunum or check till ileum. So here, if you see this code 44360, it says small intestinal endoscopy, enteroscopy beyond second portion of duodenum, including ileum. Sorry, not including ileum. So when the doctor does the endoscopy only for duodenum and jejunum, then I code by using this code descriptor 44360 onwards. All codes, they do not include ileum. But if you go down and see this code 44376 onwards, all these codes are again for endoscopy, but beyond second portion of duodenum, including ileum. So when I do it for the entire length of esophagus, I should code it by using this code descriptor 44376 onwards. All the codes are including ileum. So always check which part of the intestine the doctor does the endoscopy for. According to that, you have to keep checking your code, changing your code, sorry. And then you have, as I told you earlier, when it's endoscopy through surgical opening. This was all endoscopies. So far we saw esophagoscopy, then EGD, ERCP, then endoscopy for small intestine and everything. This is when I do the endoscopy through the natural opening, either through nose, mouth, or anus. If I do endoscopy for any of these organs through surgical opening, then my codes are listed here. Endoscopy stomal. And the small intestine endoscopy part, you will find these codes. When I am performing endoscopy through stoma, okay, like we saw, when I do the endoscopy of esophagus, we call it as esophagoscopy. When I do it for esophagus, stomach, and duodenum, I call it as EGD, esophagogastroduodenoscopy. When I do it for the ducts of liver, gallbladder, and pancreas, I call it as ERCP, endoscopic retrograde cholangiopancreaticography. Now going from the side, this anal side, if I do the endoscopy of anus alone, then I call it as anoscopy. If I am going to do the endoscopy of anus and rectum, till here I am visualizing everything, then I call it as proctoscopy. If I am going further, anus, rectum, and this till sigmoid colon I am checking, then I call it as proctosigmoidoscopy. If I'm going further, pushing the scope from anus, rectum, sigmoid colon, and some part of this descending colon, if I'm checking till here, then I call it as sigmoidoscopy. And if I check the entire large intestine, till here, till the junction of small and large intestine. I'm checking everything. Then I call it as colonoscopy. So you have to remember these terms like endoscopy, proctosigmoidoscopy, sigmoidoscopy, and colonoscopy. Similar way, esophagoscopy, EGD, ERCP, duodenoscopy, ileoscopy, and all this jejunoscopy and so on. All these words you have to just know what they refer for. And already I mentioned about the modifiers. If the doctor was supposed to do some procedure and he is not going to do that entire visualization of the organ, then you use your modifiers 52 or 53 when required. Like say my patient was planned for colonoscopy. Okay, the doctor should visualize from anus, rectum, sigmoid colon, descending colon, transverse colon, ascending colon, everything the doctor should visualize. But say doctor is visualizing only here, till here, sigmoid colon. I will not code it as sigmoidoscopy or proctosigmoidoscopy. I will code it as colonoscopy with modifier 52 or 53 because the preparation of the patient is done for colonoscopy. So the preoperative work involves for colonoscopy, not for proctosigmoidoscopy or sigmoidoscopy, right? So always use the codes with the modifiers when it's a therapeutic procedure plan. If it's a diagnostic procedure plan, like I want to diagnose what is wrong inside the colon. Only diagnostic colonoscopy I wanted to do, but I could not reach till here, till the junction of small and large intestine. I stopped somewhere in between. Then I will change my term. When it's a diagnostic procedure plan and I am not visualizing the entire organ, then change your term depending on till where the doctor has visualized. But if it's a therapeutic procedure plan and the doctor could not reach out to that particular part, then code it as planned, whatever procedure with modifiers 52 or 53. Am I clear on this?
I'm confused actually. For 52, you said, yeah, like if the procedure not done for all, but only just short part, and 53
if the doctor stopped for some medical reason,
yeah.
Then 53 modifier you use.
But here you said if, like, for example, we do only short part, why we need to use 53?
Here is the decision tree in your, wait.
It's like the procedure is done that only for short part.
Yes, but then you change your term. I'll show you, wait. I want you to open your page number 371. Page number 371. If you see, there is a tree diagram given for colonoscopy. Say I have planned for colonoscopy. Okay, the procedure planned is colonoscopy. So I should code for colonoscopy when the doctor does colonoscopy. But if he stops in between, then what do? I code colonoscopy with modifier 52 or 53 when it's a therapeutic procedure. But if it's a diagnostic procedure, I need to change my terms sometimes. Why? If you see here, they have given a decision tree. If it's a diagnostic procedure or therapeutic procedure, you have to first check. If the doctor could not reach the splenic flexure, when it's a diagnostic procedure plan, and splenic flexure, you know where it is? Here. Your spleen is located somewhere here, this part. So this portion of the large intestine, it is called as splenic flexure, this particular part where transverse colon and this descending colon meet, it's called as splenic flexure because spleen is located. And if you see this part, it is called as hepatic flexure, this part of the small large intestine, because liver is located there. So you call it as hepatic flexure. So if the doctor while doing colonoscopy, he should reach till here. If he could not reach this portion also, he has passed the scope through anus, rectum, sigmoid colon, descending colon, and he could not reach here also. Then what do? I code it as a proctosigmoidoscopy or sigmoidoscopy. Okay, so depending on where the doctor has reached. So here If he do not reach the splenic flexure, then code it as a sigmoidoscopy. You'll change your term. So better you use this decision tree when you're coding for colonoscopy. Because usually we use modifiers 52 and 53 for coding it. But here it's different depending on where the doctor has reached. So if the doctor passes the splenic flexure, he goes beyond splenic flexure, but he has not reached the junction of small and large intestine, then you still code it as colonoscopy, but with modifier 53. Okay. So that is how the term you can change either, or you code it as the same procedure with modifier, but that depends on whether it was a diagnostic procedure or therapeutic. Okay. So I was at endoscopy through stoma, right? So below this endoscopy stomal, you have this all definitions, whatever I just mentioned. What is called as proctosigmoidoscopy, what is sigmoidoscopy, colonoscopy, all definitions are given. Below that endoscopy stomal, the doctor is first of all inserting the endoscope through the surgical opening. Then I use these codes. The first code starting with 44380, these are the codes for ileoscopy. Ileoscopy through stoma. In the code description itself, they mention through stoma means it through the surgical opening. If ileoscopy is done through the natural opening, where should I go? To the previous part. The endoscopy under small intestine, it was listed, this endoscopy small intestine. There I go and I code it from here, ileoscopy. But if it is done through stoma, then I have to choose this code starting from 44380 onwards. If you go further, you will have starting from the code 44388. You have colonoscopy through stoma. So it's colonoscopy through stoma listed. Then if you go further, okay, that was all endoscopy through stoma listed under small intestine. Then you have introduction codes for small intestine, repair code, other procedure code. These are direct codes, no specific guidelines. Then you have Michael's diverticulum and mesentery. These are nothing but the membranes which are going to hold your abdominal organs together. Otherwise, the organs will keep moving here and there into your abdominal cavity. To keep them in their place, you do have these membranes to hold them in place. If at all you are performing any procedures on these membranes, then the codes are here. Very few codes are there. Excision, sutures, and other procedure codes. That's it. Then appendix related all codes I have discussed in the first class, if you remember. When we are doing appendectomy, whether it's done as open procedure or closed procedure, what was the reason to perform appendectomy? Based on that, you choose your code. So all these codes we have already discussed. I'll not go into the details now. The last part of the digestive tract is colon and rectum. So if at all you are performing the procedure on colon and rectum, that is your large intestine and rectum, then again the same procedures are listed: incision, excision, then repair, destruction, endoscopy. So endoscopy, already I discussed these terms: proctoscopy, proctosigmoidoscopy and all. So these all codes are listed here. Which part of the large intestine you are going to visualize, depending on that different codes are there. Starting from 45300, you have all codes for proctosigmoidoscopy. When the doctor visualizes only anus, rectum and part of sigmoid colon, then these all codes you can use. If you go ahead, you will see starting from the code 45330 onwards. 45330 onwards, all codes are for sigmoidoscopy. If you go further down, you will see starting from 45378 onwards. 45378 onwards, all codes are for colonoscopy. Okay. So always check what type of endoscopy you're coding. Proctosigmoidoscopy, sigmoidoscopy, colonoscopy. Go to that code range and then assign your codes. This is all endoscopy through natural opening. If it is done through surgical opening, go to the previous part, endoscopy stomal, and code it from there. After this endoscopy for large intestine, you have got laparoscopy, repair codes for large intestine, and so on. These are direct codes. There are no specific guidelines. Coming to the last part of the digestive tract, anus. Anal region, again, similar procedures will be listed. That you have got incision procedure, excision, repair, destruction, or endoscopy, and so on. The only procedure for which you have guidelines here is the treatment of hemorrhoids. Hemorrhoids is a common condition seen into anal region where the blood vessels which are supplying to your intestines, these blood vessels, they protrude into the anal region, either inside the anal region. So there is a line, okay? There are muscles, anal muscles. So there is one sphincter, that is external sphincter for your anal region. So if the hemorrhoids, they protrude above that, you call them as internal hemorrhoids. These blood vessels, they engorge, they are thrombosed, they are just swollen and they protrude inside. So that is a internal hemorrhoid. But if they protrude so much that they are hanging down the anus, outside visible, then you call them as external hemorrhoids. Whenever the treatment of hemorrhoids is performed, treatment will be simple. You just ligate these hemorrhoids, whatever these blood vessels, rubber bands are applied over that. That is a simple treatment. But sometimes you treat it by excision. You remove those engorged vessels or some other treatments you apply. So how you treat, based on that, code will keep on changing. Whether you are treating an internal hemorrhoid or external. How you are treating it, by rubber band ligation or by some other method. Based on that, code will change. Again, these vessels, when they protrude, they will usually protrude into groups. Each group is called as a column. So how many columns I'm treating? One single group or two groups, three groups together. So how many groups I treat, depending on that, code will change. So these three things you have to check, whether internal hemorrhoids, external. How you are going to treat it, by rubber band ligation or by some other method. Whether you are going to treat one column or multiple columns. These all things you match and you code it. Here you will find few combination codes again. So here, if you see anal region, incision codes are direct. I was talking about hemorrhoids. So when hemorrhoidectomy is the procedure, removal of these hemorrhoids, when I do it, the codes will be listed under excision. If you see the code starting from 46221, it is hemorrhoidectomy internal. When I'm treating internal hemorrhoids by rubber band ligation, then I go with this code descriptor 221. If you see the next code, it is hemorrhoidectomy again for internal hemorrhoids, but the treatment method, if you see, it's by ligation other rubber band. Okay, and whenever the treatment method is other than rubber band ligation, I have found how many groups are treated. If it's single group, the code is 46945. If multiple groups I am treating, then 46946 is the code. Two or more columns are treated, the next code you have to use. This is all these different codes for treatment of internal hemorrhoids. Similar way, you will find it for external hemorrhoids. So starting from the code 46250 onwards, you have codes for hemorrhoidectomy external. So when external hemorrhoids are treated, you do have this code for two or more columns. If single group of external hemorrhoids is treated, you do not have any code. There is no code available for the treatment of single column external hemorrhoids. So when the code is not available, what you do, you go along with unlisted procedure codes. So can you see the guideline here? The note written below the code 250. For hemorrhoidectomy, external, single column or group, use 46999. Mostly your codes ending with 99 or 999. These codes will be unlisted procedure codes. So if you want to code for single column, you can use this unlisted procedure code. And then there are combination codes. So 46255, Onwards, all these codes are combination codes when I am going to treat internal as well as external hemorrhoids together in the same operative session. Then I am going to use this combination code. When combination codes are available, do not code treatment of internal hemorrhoids separately and external hemorrhoids separately. Always use a combination code. So this is for single column treatment. If they are treating multiple columns, then 46260 onwards, these codes are for 2 or more columns. That was for hemorrhoidectomy. Then you have codes for introduction. So when you insert any medical device into the anal region, the codes are there. Then endoscopy codes for anal region. So endoscopy of anus is called as anoscopy. So all these anoscopy codes are listed here. The guidelines are same. You check diagnostic or therapeutic procedure. You will check whether rigid scope or a flexible scope is used and everything, whatever we discussed earlier. Same endoscopy guidelines you apply and code. Then repair codes for anal region. Anoplasty codes are there. These are also direct codes. So this is all related to anus is direct.
Open hemorrhoids. Open hemorrhoids.
Open procedure. Hemorrhoids can either be internal or external. Treatment is either open treatment or closed treatment. For every procedure, it will be there. But open treatment usually we don't do for hemorrhoids. It's usually visible outside if external hemorrhoids. So no need to open up the patient. You just ligate it there, done.
Because actually sometimes my doctor is asking for open hemorrhoids as well.
Open hemorrhoids.
Yeah.
There is nothing like open hemorrhoids. I'm not sure of.
For the name of the procedure, it's like open hemorrhoids.
Hemorrhoidectomy is the procedure. Removal of hemorrhoids. Open, if you do it open, maybe the doctor is calling that as open hemorrhoids. I don't know. But the type of hemorrhoids are either internal or external. Okay. So that was all about the digestive tract. So far, we were checking the codes for digestive tract starting from mouth till anal region. Hereafter, you will find the codes for digestive glands. That is your liver, gallbladder, and pancreas. For liver, the medical term is hepato. So hepatotomy, hepatectomy, hepatitis, and so on. These words all refer to your liver. Gallbladder, the other name for gallbladder is cholecyst. So cholecystitis, cholecystectomy, or cholelithiasis, very common condition. So stones into the gallbladder, gallstones. It is called as cholelithiasis. So removal of the stones and everything, all these procedures you'll find in here. And pancreas, you know already pancreas. This is the organ secreting insulin. So here, liver, all codes, very direct codes. There are no specific guidelines for liver. So incision procedure, excision, then you will have transplant codes for liver. So again, transplant done into 3 steps. You already know that. Then repair codes, laparoscopy codes. So there are no guidelines absolutely for coding any procedure under liver. After liver, you have got biliary tract. Biliary tract includes all the ducts which carry bile. So from liver, bile is secreted. This bile, once it is secreted, it is carried to gallbladder. It is stored there for some time. And when there is presence of food into your intestine, then the gallbladder will release this bile into the small intestine. So from liver to gallbladder, it has to be carried. From gallbladder again to the intestine, this bile has to be carried. So whatever ducts carry this bile, including your gallbladder, they fall under biliary tract. All the codes for the biliary tract will be listed, which includes the code for gallbladder also. So here you will find all your codes for cholecystectomy or cholelithiasis. For that, whatever treatments are done, those all treatments you will find in here. These codes again are direct codes, and there are tables in between if you are going to code for like the drainage of the bile and everything. For that you insert some catheters and everything. So all these codes are there which are direct codes, and you have to read the entire description of the code, match with your patient's record, and assign the code, because there are no guidelines but the codes are very much descriptive. After this liver, gallbladder, that is biliary tract, you have got the last organ, the last digestive gland, pancreas. Pancreas also, all codes will be very direct codes: incision, excision, repair, laparoscopy, endoscopy, and so on. So there are again no specific guidelines for the organ pancreas also. All these codes are simple codes. The last part into digestive system is abdomen, peritoneum, and omentum. I told you these are the protective membranes to protect all your abdominal organs. Whenever you do any procedure on your abdominal muscles or skin over the abdomen or fascia and so on, the codes will be here. Basically, when you operate only on skin, the codes will be into integumentary system. If you are operating on the entire this thickness of the abdominal wall, then the codes will be here. Okay, that includes your abdomen, peritoneum, and omentum. So peritoneal membrane, that is the membrane which is binding all your abdominal organs together as well as keeping them safe. Then over the peritoneum, you will have abdominal wall, which is composed of muscles, fascia, and skin. When I'm going to operate on any of this, the codes are here. The procedures are same: incision, excision, repair, and so on. The commonly seen condition with abdominal wall is hernia. When I'm going to treat hernias, there are codes separately listed. So here, if you go incision procedure, all codes are direct, no guidelines. After incision, you have got excision procedure. So if you are removing any tumor from the abdomen, any polyp or anything, biopsy sample or anything like that, or any other different procedures you are performing on abdominal wall, the codes are under excision. After excision, you have laparoscopy. If you perform any procedure on the abdominal wall by laparoscopic method, the codes are here. Have you heard of this liposuction procedure? Usually for, this is again a cosmetic, usually cosmetic procedure. The fat layer on the abdomen, they just melt this layer and remove it by suction. It is called as liposuction. So this is again usually done for reducing the abdominal size, not size, but you just for the cosmetic reasons, for the better looks, you get it removed. When you do that, usually these procedures are listed under laparoscopy, all liposuction and everything, whatever is done. Then you have introduction, revision, and removal. If you are inserting anything into the abdominal wall or into the peritoneum, like any shunt or any other device, if you are inserting, the codes will be listed here. After that, you have got, okay, these are all under laparoscopy only, all these codes are there: initial, placement, replacement, and everything. Then you have got the codes for repair, which I was talking about. Here you have guidelines. When you are treating for hernias, when any hernia is treated, first of all, hernias are classified by 3 different methods. First, you classify them based on their location, where that hernia is located on the abdomen. Your abdomen is divided into 9 different quadrants. So where exactly that hernia is located, based on that you classify it as epigastric, inguinal, femoral, or if it's around the umbilicus, you call it as umbilical, and so on. So depending on the location of the hernia, hernias are classified. The next classification depends on whether the hernia has happened for the first time or it's recurrent. Like say hernia, what is hernia? Hernia is nothing but when there is a weakness into the abdominal wall. Abdominal wall is keeping all your abdominal organs intact inside. But if the abdominal wall is weak, muscles are lax or something, some weakness is there, all your intestines, they will protrude from that weakness. When they protrude, you call it as hernia. That bulge on the abdomen, what you see is called as hernia. This hernia, when it happened for the first time, I call it as initial. But say I have treated that hernia, I put back all those contents, I repaired it, sutured it, treated that weakness, and later on from the same location, it's coming back. Then I call it as recurrent. So if it's recurrent or initial, that is another classification. And one more classification depends on presentation. When my patient is coming with hernia, so say when the doctor does the examination, it's say umbilical hernia, protrusion around the umbilical region. I'm applying pressure over that area. When I apply pressure, all the intestines will go back inside. Inside the abdomen, they will go back. I call it as reducible hernia. If the contents of this abdomen, that is intestines, are protruding out, patient came to me, I'm applying pressure to put them back, but still they are not going inside. Then I call it as incarcerated hernia. The third type is strangulated hernia. When the contents are protruding out, I'm applying pressure, but still they are not going back. And that the contents are coming through a very small opening, through a small weakness, and that large contents are protruding out. What will happen? Pressure is created. Pressure is created on the part of the intestine which is lying outside. So there will be lack of blood supply and necrosis will settle in. All the tissues will die, and then gangrene and so forth. The complications will happen. If that is there, then I call it as strangulated hernia. So depending on the presentation, I classify it as either reducible, incarcerated, or strangulated. Depending on whether it's first time or recurrent, I call it as initial or recurrent. And depending on the location, you do have different types like umbilical, epigastric, femoral, inguinal, and so on. Whenever you are coding for hernias, any hernia repair is performed, check whether it's hernioplasty, herniorrhaphy, or herniatomy procedure. Based on that, different codes will be there. Another thing is you have to match the entire type of hernia. Whether it is, say it can be umbilical hernia, but reducible also. So umbilical reducible hernia, that will be the description written in the record, or umbilical initial reducible hernia. So all combination of this different classifications, what I told you, will be written into the record. That entire classification you have to match with your code description. Another thing is, when you are coding, you have to check the age of the patient. All your codes will be age specific. Whether your patient is less than 6 years, more than 6 years, 12 years, like all, depending on the age group of the patient, the codes will be different. Another thing is the length of the hernia. So how big that hernia is. I'm treating 2 centimeter length, 4 centimeters, 6 centimeter, how big that repair was done. That is depending on that, the codes will change. Now, as I said, length of repair you have to consider. Now, say I'm treating this umbilical hernia. Okay, this is 2 centimeter. Along with the umbilical hernia, there is epigastric hernia also in my patient. I'm treating that same epigastric hernia also in the same session. I'm treating 2 hernias in the same session. Both of them are 2 centimeter wide. When I am treating, I will not code for 2 and 2 centimeters separately. What I will do is I will consider the entire length of repair, because when I treat such hernias, I will not cut open the patient in 2 different locations. I will take the entire incision, I will put back everything inside, and I will place a mesh. Mesh placement is a common thing, that you just use a wire gauze like structure will be there. You place it inside so that the contents will not protrude again. So that mesh will be placed, and then I'll repair everything together. So say this was 2 centimeter and this was 2 centimeter, and there was a distance in between them that was another 2 centimeters. When I'm going to code, I will code for the entire length from this point to this point, whatever the entire length, that is total 6 centimeters, I will code it for. I will not code separately 2 and 2. Okay. Same way for the others also, like this and this being treated together. So I will take this entire length of repair. Whenever I am going to code, check the entire length being repaired. Even the distance between them will be calculated as the length of repair. Okay. Okay, and that mesh placement which I said earlier, that mesh placement is a part of your hernia repair. For mesh placement, you will not code separately. Okay, do not use any separate code for mesh placement. Here, if you see under this repair, hernioplasty, herniorrhaphy, and herniotomy procedures are listed. In the very first paragraph, you will see they have given the classification depending on the location. Inguinal, femoral, lumbar, omphalocele, anterior, abdominal, parastomal, and so on. Okay, one more thing, one more guideline I forgot to mention. When I described about reducible, incarcerated, and strangulated hernia. Reducible hernia is a simple type because you push back everything, it will go inside. Incarcerated is more complex compared to reducible, and strangulated is the most complex one. Now I just explained you about the length of repair. So say I am treating these two hernias. One is umbilical hernia and the other is a epigastric hernia. Epigastric hernia is incarcerated and this umbilical hernia is reducible. So two different types are there. I'm treating these two different types of hernias in the same operative session. When I'm coding, I'm going to use one code for the entire length of repair. So should I code it as repair of reducible hernia or repair of incarcerated hernia? When that is the scenario, you will code for the most complex type. If it's reducible and incarcerated, code it as a incarcerated. Both consider them as incarcerated and code them as incarcerated hernia repair. If it's between incarcerated or strangulated, consider it to be strangulated. Okay. So whichever is the most complex type of hernia of this all, whatever you are treating together, you have to code for the most complex type. Okay. Going back to the guidelines. So first paragraph, depending on the location, all this classification is given. Then the second paragraph, you will see what is initial and recurrent. They have mentioned. Third paragraph, if you see, they have mentioned what is reducible, incarcerated, strangulated. And then your codes are there. All these codes, like I told you, to match the things. Entire type of the hernia you have to match. The age of the patient you have to match. And the type of repair they do. Like whether it's herniotomy, herniorrhaphy, or hernioplasty, whatever they do. Based on that, you have to code it. All different types of hernias and the length of repair also you have to match, and based on that you code it. The other guideline which I mentioned about the length, it is written on page number 393, last paragraph. If you read that paragraph, you'll understand about the length of repair. What I explained is all written there. You can highlight it and read it later. So that was all about hernia repair. Here in the diagram also they have explained. Like these three different hernias, they are repairing of different length, but you just consider the entire length when you consider the length of repair. Last thing under this abdominal wall is laparoscopy. So whatever hernia repair codes we discussed, if they do it as an open repair, then the codes will be listed under that section of hernioplasty, herniorrhaphy. But if at all they repair the hernia by closed method, by laparoscopy, the codes will be listed under laparoscopy section. And lastly, you have codes for sutures and other procedures. These are simple direct codes. That was all into digestive system. Any doubts? It's a long chapter, but very few guidelines are there. The guidelines you will find when we are coding for endoscopies. You have to pay attention for which part the endoscopy is done and appropriately use your modifiers 52, 53 when required for endoscopy. Endoscopy, when it is done for stomach and duodenum, it is listed under esophagus. And when it's endoscopy through surgical opening, it is listed under small intestine. Then there are few combination codes which we saw for adenoidectomy and tonsillectomy. Then there are few combination codes for internal and external hemorrhoid repair. And then there are guidelines for repair of hernia. Otherwise, in the entire topic, you will not have any guidelines. Okay. So here, always when you're coding, you're going to check which organ into the digestive tract they are repairing. you will go to that organ, then check what is the procedure they are doing. Incision, excision, repair, endoscopy, laparoscopy. Based on that, you will go to the code range and then you will start searching for the code. I'll mark few questions. You can do these questions by your next class, okay? Okay. There's 7 questions I have marked. First 4 questions, then question number 11, 12, and 14 you will do. And then we will discuss the answers in the next class. You can take your own time, solve these questions by next week. Then, any doubts so far?
Ma'am.
Okay. So with this, I will stop for today and we'll continue in the next class.